one, go.
Good evening, everyone, and a warm welcome on behalf of Shield Healthcare. I'm Dr. Prachi, and thank you very much for joining today's webinar. Today's webinar is brought to you by Karnataka Ops and Gynecology Association in association with Southwest Zone, which includes Shivmoga, Chikmagalur, Mangalore, Manipal, Hassan, and Gulbarga OBG societies. Today's webinar topic is preterm labor and rupture of membranes. And I'm very happy to introduce and honored to introduce today's Master of Ceremony, Dr. Raksha Rao. Ma'am is a consultant at Usha Nursing Home, Shivmoga. And she has various interests like colposcopy, high-risk pregnancy, non-descent vaginal hysterectomy, social obstetrics, etc. And Ma'am is currently Vice President of SOGS and Secretary of IMA, Shivmoga. So with this, I hand over to the session to Ma'am Raksha Rao. Over to you, Ma'am, and thank you very much.
Good evening, everyone, and thank you for that warm introduction, Dr. Prachi. It's very fortunate for me as Vice President, Shimoga Obstetric and Gynecological Society to anchor this webinar on a very important topic in the day-to-day practice of OB-GYN, that is preterm labor and PPROM. We are fortunate to have the presence of many stalwarts and bigwigs in this webinar. And to start with, I request the Chief Convener, our very own Dr. Shanta Shekhar Ma'am of Shimoga Obstetric and Gynecological Society, to welcome the gathering.
Good evening, all. It gives me immense pleasure on my behalf as well as on Kasoga team behalf to welcome you all for this wonderful evening's program on preterm labor and PPROM. I extend a warm welcome to our beloved dynamic President of Kasoga, Dr. Vidya Tobi ma'am. I welcome our chief guest for today's program, Chief Patron of Kasoga, Dr. M.G. Hiramet sir. I welcome Dr. Hema Divakar ma'am, who has not logged in, I think. I welcome our guest of honor, Dr. H. Nagaraj sir, who is patron of Kasoga and our patron of Shimoga OBG Society. I welcome Dr. Sheila Mane ma'am. She is the Iron Lady for PPH programs. I also welcome our own chief coordinator of today's program, Dr. Sneha Bhuyar ma'am, who is instrumental for this Kasoga program this evening. A very warm welcome to you, ma'am. And also I wish ma'am a very much success in her election as Vice President. We would like to see you as Vice President of our FOXY.
Thank you so much.
I welcome our dynamic Secretary of Kasoga, Dr. Rajeshri Paladi, who is instrumental for many of our Kasoga programs. I welcome our Kasoga Treasurer, Dr. Suman Gaddi ma'am. I welcome Dr. Kasturi Donimat, who is going to speak to us this evening. She is the immediate past president of Kasoga. I welcome our chairpersons, Dr. Shaila Jaiprakash, SOX President, Dr. Vishalakshi Mugi, SOX past President, Dr. Ashwini Pai, Dr. Raksha Rao, who is already doing her Master of Ceremony now. I will use my warm welcome to co-convener, Dr. Sonia Batra. I also welcome all the panelists who are there here for this webinar, Dr. Sri Lakshmi KN, Dr. Hema Mohan, Dr. Shushma HP, Dr. Sonia Batra, Dr. Sheila Lohit, and Dr. Pandurangaya. I also welcome Shield Dr. Prachi, who is already logged in for us. I welcome all the delegates who have logged for this webinar. A very warm welcome to one and all for this webinar. I now hand over to Dr. Raksha Rao for the next proceedings.
I would like to recognize the presence of the chief guest of today's webinar, Dr. Hema Divakar ma'am, who come to believe that has logged in from all the way from Sri Lanka. A very warm welcome to you, ma'am. Hema ma'am.
Namaskara.
Namaste, ma'am.
Good evening and warm welcome, Hema Madam.
Namaste, namaste, Hema.
Namaste.
Namaskara.
Nice to see all of you. Namaskara.
Vidya, namaskara.
Namaste.
I was searching you, whether you and Hema. I was waiting.
Yes.
Nagaraj sir kanta idare. Namaskara sir.
Namaskara to all.
Namaste to all. From me as well.
Namaste, Hema ma'am.
Please,
Kasturi,
Sneha,
Dr.
all Kasoga leaders are here. for you.
Yes, I think all of you are
All the
blessed.
best for you.
Namaskaraಗಳು.
Galu.
So everybody included.
Yeah.
Namaste, ma'am.
Namaskaram.
Namaste, sir. Good evening, everybody.
Yeah. Good evening.
That sweet exchange of
Neha,
pleasant.
ma'am, all the best.
I would also like to welcome Secretary Kasoga, Dr. Rajashri Paladi, ma'am, who has just now logged in. Welcome, ma'am. And also the speaker of today's first session, Dr. Kasturi Donimat, ma'am, past president of Kasoga. A warm welcome to you as well, ma'am. Yeah. So before the inauguration, let me take this opportunity to invite our president Kasoga, Dr. Vidya Tobi, ma'am, to kindly introduce the key coordinator of this webinar, Dr. Sneha Buyar, ma'am, to the gathering. May I request Dr. Prachi to share the slide, please?
Yes, welcome all the dignitaries of Kasoga. And I'm really pleased to introduce my dear friend, Dr. Sneha Buyar. She has got excellent academic career, as well as she has got many awards and accolades to her credit. She has done her successful completion of her breast committee, and I think she has done many, I think more than 1,000 programs. Now again the breastfeeding week has come, and again I remember Sneha appealing to every society to do this program. She did one excellent BreastCon conference also in Pune. So she has also organized, she has got very good organizational capacity, and I think she was part of many, she has organized conference. Though she comes from very small Yavatmal society, but she has made her impact all over, almost at the national level. She has got many talks, many publications. If I go on reading her all CV, I think it is in pages, and I think it will take 15 minutes. I take this opportunity to wish her all the best. And she is for Vice President Foxy, and the elections have already begun. So I request everyone to support her and vote for her. Voting is very important. Even though you like a person and you like everyone to come up, but Sneha is a person who takes everyone along with her, and she gives equal opportunities with her. She takes all the people along. So the leader should be like this. The leader should take everybody along. They should guide at each step. So I think everybody agrees for that. And all the best, Neha. And we are looking forward. And this program on preterm labor is specifically designed by Sneha. So I was a part of her many webinars. She talks very freely in any high risk pregnancies you take, apart from her breastfeeding and other things. So this program is definitely specifically for preterm labor. And I must congratulate my Kasoga people, especially the South Zone. Dr. Shanta Shekhar, one call I made that one from your zone, I need one program. All zones are doing well. One program she wanted to do physical, but I told at least come up before our Yuva Kasoga one webinar. So she immediately agreed. She gathered the people, she gathered the good people, and I think this is going to rock. So congratulations, Shanta, for arranging. I think from Shumoga and all, everybody joined. MG Hiramet sir's blessings, Hema's blessings, and Nagaraj sir blessings are there. My team is here, Rajashri, as well as Dr. Suman Gaddi and our own Sheila Mane. So let us look forward a great academic session. All the best, Neha, again. Thank you very much.
Thank you so much. Thank you.
Vidya Tobi, ma'am, for that pleasant introduction. We have two stalwarts as chief guests for today's webinar, Dr. MG Hiramat sir and Dr. Hema Divakar, ma'am. These two big wigs actually don't need any introduction. Dr. MG Hiramat sir has been the chief patron and founder secretary of Kasoga. He is the principal of KLKS GMM Medical College, Hubballi, and president of Rangavaidyaru Cultural Association, Hubli. He holds many prestigious positions and is a well-known name in the field of OB-GYN in both the state and national level. Very warm welcome to you, sir. And I would like to introduce Dr. Hema Divakar ma'am, who has come to this webinar with her smiling face as usual. She is the medical director of Divakar Specialty Hospital. She is a CEO and chairman of Asian Research and Training Institute for Skill Transfer. She is the Dean of KCOG, Vice President of Karnataka AHPI, Chair of Well Women Healthcare. She is the past president of Foxy 2013, and she is an advocate for delivering quality healthcare convener Manyata. I now request the chief guest to give their pearls of wisdom to begin this webinar. So Dr. M.G. Hiramat, sir.
Thank you for your nice introduction. Yeah, can you hear me?
Yes, sir.
It's a pleasure to be always with Hema, who has connected from Sri Lanka. And all the stalwarts of Kasoga, Dr. Nagaraj, Dr. Sheila Mane, Dr. Vidya Thobi, Dr. Kasturi, whole Kasoga is here, we are Sneha for it. And Sneha and Shanta have made this program and this topic, which is very close to my heart. For many, many years, I go on talking on this preterm labor and PPROM because this is the problem what we are facing day in and day out. And more than 30% of the deliveries are ending with preterm labor. And you know that preterm labor has become the biggest problem now. In spite of so many new inventions, still we are not able to salvage the pregnancy up to term. And now there are so many new recent advances have come. Even the classification has changed a lot. And if you go by this, all this classification, management of preterm labor will be very, very difficult. And so many new things have come. I think today's speakers, I don't want to come in the way of the knowledge and their presentation. Just I want to say that if we prevent the preterm labor, we are going a great thing to the whole our women community, because what we want is a healthy mother and a healthy baby. And healthy baby is one which has crossed 38 weeks. Any baby is born before 38 weeks, it has got its own problem. Maybe that it may be taken to NICU, maybe it may be treated by neonatal, maybe that you are giving glucocorticoids, you are giving so many things. Still, the natural thing, what is getting it in the womb is nothing can replace it. Always try to carry on the pregnancy, at least to an extent of 38 weeks, may not be possible 36 weeks. If that is also not possible, at least 34 weeks. I feel 34 is the zone where you should reach in spite of all the efforts. Today's speakers are going to highlight. I once again thank Sneha and Shanta. Sneha, all the best for you. You have done so much in Foxy over the years. We would like to see you as Vice President. That is our heartfelt feeling, which I would like to express to you, Sneha, because you also took up the same committee, what I enjoyed for a long time. And I would like to confess that you did much, much better what we could have done during our time, because you dedicated so much. And anybody, whoever is dedicated, they will give a very good job. And Sneha is an example for that. Thank you, Sneha, and thank you all of you. I do not want to take much time. With these words, I wish a grand success for this program.
Thank you so much, sir. Thank you.
For those wise words, sir. We would now like to listen to the inspiring words from Dr. Hema Divakar ma'am. Ma'am, please.
Ellarigu namaskara. Beyond the geographic boundaries, there are two things that are strongly connecting us today. One is Vidya, which means knowledge and dissemination. And the other is Sneha, which is friendship. And we would rush from anywhere across the globe to stand in support for you, Sneha, for sure. And then Vidya Thobi said that it's all about taking people together. And it is so true of our organization, Kasoga. If it was not for Hiramat or Nagaraj sir, I do not think that we would have stayed together for so long, because Hiramat, in his description of Kasoga, one of the Bangalore conferences of Kasoga, he said the Kasoga has finished its term and then delivered a neonatal baby, and then it is now toddler and teenager, and now he's handed over to Vidya to be in a mature state. So she's safe and comfortable, and all of us are, with the added, ease with which Dr. Shanta Shekhar and Raksha can put us together on a virtual platform, thanks to the technology, and we can all be with each other to do as much and even more as we can. There are two important points I just want to place, that preterm and Prom very closely linked with situation of anemia, which is in 50% of our women. And I am in Sri Lanka because for the last 12 years, what we have been using right, left and center in our country, the ferrous ascorbate, because of vitamin C enhances the absorption of iron. So it is one of our most preferred oral iron tablets to correct the anemia. Sri Lanka has just given the license last month, and the product of ferrous ascorbate, 12 years we are ahead of Sri Lanka in that sense. It was just launched yesterday and will be made available in another 2 weeks to all the clinicians. So they wanted to know the India story of how it is. Again, how India is leading the anemia issues is the WHO has called for a consultative meeting next month. WHO has not said a single word about parenteral iron. And they again want to get the experience in India, where we have been using the parenteral iron right, left, and center, and it's also in our national recommendation. So, dear friends, it is again a huge leap ahead, even with technology and artificial intelligence and the role modeling and leaders, we being the first. We are so very proud of the talent that we bring in onto the forum. And in keeping with the breastfeeding week, I must once again congratulate the previous breastfeeding committee chairman, Dr. Hiremat, and the present breastfeeding committee chairman who just finished her tenure. And it's all about think nutrition first, think breastfeeding in the first hour after birth. Just today, the FIGO has released a position statement on it as well. And it's well in keeping with each one of us, what we can do and what we must do. So with that, we again wish this togetherness to stay for all times, so that the synergies can be put to use to give the best impact and the care to our girls and women, not only in Karnataka, not only in India, but to the global voice of FIGO as well. So thank you very, very much for having me here. I was very doubtful whether I could join or not, but God is there always helping me connect with my very near and dear ones. Thank you very much.
Wherever you are in the globe, you are here.
Yeah, absolutely.
I always tell that FIGO must be your brain, but Kasoga is your heart.
Right?
Except when she goes to space.
Yeah. No, still then she will
We
connect.
can go anywhere. Okay. Thank you very much, Dr. Hema, for joining. Thank you.
Mama, for those motivating words and also throwing the light on the connection between preterm labor and anemia. And I also like the perspective between Vidya and Sneha that you put across. Thank you so much. Now we'll, before letting the chief guest talk, we'll move ahead with the inauguration, which had supposed to happen before this. So I kindly request Dr. Prachi to put the inauguration slide, seeking the blessings of the Almighty.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatrubuddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhanasampada Shubham Kurutvam Kalyanam Arogyam.
Thank you very much. From from darkness towards light and from ignorance towards knowledge. That is what most of the webinars are based on. So with that thought, we'll move ahead with the introduction of the chief guest. We have with us our very own Dr. Nagaraj sir, who is not only the Bhishma Pitamaha of Shimoga Obichi Society, but Kasoga as well. He has a wide range of experience of over 54 years, and he's the patron of Kasoga, former president of Kasoga, EC member of Kasoga, and he was the founder president of Shimoga Obigain Society. He has organized Kasoga state conferences 2005 and 2017. And he was a former president of IMA Shimoga. I can proudly say that sir is part of almost all the doctor associations in Shimoga, and none of the conferences, even other specialty conferences, happen without sir's guidance. So it's a privilege to have Dr. H. Nagaraj sir with us. So kindly please give your words of wisdom to this webinar.
Sir, please unmute yourself.
Am I audible? Hello?
Yes, sir.
Yes, sir.
Namaskar. Thank you very much for the kind words. I do not know how much I deserve it. Chief patron, chief guest of this today's webinar, Dr. M.G. Hiremat, chief patron of Kasoga, Dr. Hema Devakar, future president of FIGO, Dr. Sheila Mane, guest of honor, Dr. Sneha Bhuyar, key organizer, Kasturi Kasoga, Dr. Shanta Shekhar and Dr. Sonia Batra, conveners, Dr. Vijay Tabbi, President Kasoga, Dr. Rajshri Paladi, Secretary General of Kasoga, Dr. Suman Gaddi, Treasurer of Kasoga. I would like to thank the organizers for the opportunity. I am happy this event is being organized by Southwest Zone of Kasoga and Gulbarga Society. Conveners are from my parent society, Dr. Shanta Shekhar and Dr. Sonia. All the societies of this zone are involved in this program. These online webinars have revolutionized our thinking and our learning process. We can sit at home and learn so many aspects of newer things. Every day we are having a webinar. It helps the postgraduates, practicing gynecologists and teaching faculty. They read and incorporate the messages to all the members of the Kasoga and all over India. In India is the capital of prematurity. It is a duty to prevent by recognizing early with proper history, clinical examination, and of course, ultrasound is the main stream for the process the cervical condition. Vaginal infections are one of the most commonest causes for preterm labor and PPRO. About a week ago, in one of the webinars, the speaker was emphasizing on cervical cups, which is going to have a big role in prevention of preterm labor. I am sure this, if it is helpful in future, every lady will have a cervical cup in her pregnancy. We are using left and right the progesterone, whether it is indicated or not. So we have to use it all judiciously. With these few remarks, I wish this webinar fruitful for all of us. I wish Dr. Sneha Bhuyar in our future proxy elections. Thank you and all.
Thank you so much, sir. Thank you.
Thank you, Nagaraj sir. It's my privilege to introduce one more chief guest of today's webinar, the very dynamic Dr. Sheila Mane ma'am, who is currently the DNB faculty at KCG Hospital, Bengaluru, and has over 42 years of experience in the field of OB-GYN. She is an ICOG governing council member, and she's the member of, her area of expertise is highest pregnancy and fetal medicine. And we all know madam for her PPH drills and war against anemia.
Thank you.
So,
Thank you, Rakshita. Thank you. Okay. So, yeah, it's very nice to see everybody here and such strong messages from all the seniors like Dr. Hirema, Dr. Nagaraj, as well as Dr. Hema Divakar. And I think it is very important, whenever the one advantage of webinar, I always feel, that you are sitting in one place and you really listen to each and every word. And, it is the wisdom from all the seniors, which tells you so many things which are so important, So many people feel why they should be chief guest and guest of honor. But it's so important, you get such important messages and so important points on that particular topic because the experience speaks. So I congratulate all the so many 6 societies of Kasoga for coming together for doing this wonderful seminar and the webinar and Dr. Sneha Buyar as well as Dr. Shanta Shekhar for conveying this on this very particular day, that is 1st August. And beginning only, I would like to wish all the best to Sneha. I must tell you that both of us from the same place, that is from Vidarbha. Okay. So she is from my Maika. Okay. Nam taur mane hudgi. Sneha. So anyway, I wish her good luck. Now, it's very important that as Dr. Hiremat told us that 30% of deliveries are still preterm. And there is so much of burden on us. And that's the reason that we are not able to still cut down on neonatal, perinatal mortality, morbidity, as well as the infant. Because this is the sick baby which grows. And one important finding which has come from this is that we are contributing, we are becoming capital for everything. We are contributing maximum cases of epilepsy also. And that is again due to birth asphyxia. And all these preterm and premature babies are asphyxiated at birth. And if not taken care, will become epileptic. So there is a WHO strategy also. The few centers in India are participating in that prevention of hypoxia, not only antenatally, intranatally, but also postnatally, which is very, very important because epilepsy is on the rise. That is one thing. Another thing I was just reading about the human brain, all of us, we know that the human brain is growing, okay, compared to the other mammals. The myelination of the human brain happens till term. And even then, only 25% of the brain is developed. Whereas in other mammals, it is 40 to 70%. So, their locomotive, their motor system is already developed, but it does not happen in human fetus. And if we deliver these, if these babies are born early, what happens is after birth, there is a rapid growth. And this rapid growth can give rise to problems in future, like cognition problems and even autism. And I think we have to really think about it, because what happens is we don't see the children. They go to pediatrician. Okay, we have resuscitated, we have sent the baby to NICU, but we don't know later on what happens. And as we have a largest population, I think more and more such webinars are required or programs are required, because we have to really look at the prediction and prevention of the preterm as well as PROM, which go hand in hand. So it's our big responsibility to prevent this so that we can have a healthy population, because our population is large and we do see so many psychological problems amongst the young children. Maybe we see more because our numbers are more. So the responsibility is on all of us. Anemia, which is very important, Dr. Hema Divakar pointed out, anemia mukta Bharat, whatever we say, if that is prevented, again, preterm birth can be prevented. And there are so many other factors also. Sir was telling even about the technology which is coming up, Nagraj sir. So there are so many things. So I think the antenatal care, which is so important, and I think all the speakers are going to talk about it, that is prediction, prevention, management, as well as there is a panel. And all nowadays I find, all these young people, they do such an excellent job, because, they will know all the new things and they will come out with their new ideas. And I'm sure that this webinar will be a really a very good webinar and deliver a correct message to all the viewers, those who are participating in this. And I wish that there is a recording available again, which can be sent to all. So those who have not attended also will be benefited President Kasoga, I would like to request that. I thank all of you for inviting me as a guest of honor here, and thank you very much.
Thank you, Dr. Sheila Mane, for that insight into long-term impact of preterm birth in neonates and especially during their infanthood. Thank you. We'll now move on with the first topic of today's session, a very practical topic, prediction and prevention of preterm labor. To speak on this topic, we have a very eminent speaker, Dr. Kasturi Donimat ma'am. And to chair the session, we have Dr. Shaila Jaiprakash ma'am, who is the president of Shimoga OBG Society, practicing at JP Aradhana Maternity Center. She is a alumni of Hubli and Belgaum, and she also worked as a medical officer at Family Planning Association of India, Shimoga, for almost 12 years, and has conducted around 12,000 tubectomies. She's worked as a consultant at the Kingdom of Bahrain for 5 years, and she has vast experience in the administration of Shimoga OBG Society. Her area of interest including fertility, and she has conducted many camps. Our next chairperson is Dr. Vishalakshi Mogi ma'am, who is a MMC and KMC alumni, and she has a strong foundation of working in government setups, right from PHC Sulebavi to Megan Hospital, which was the district hospital in Shimoga, the General Hospital Bhadravati. And as a senior medical officer, she took voluntary retirement and joined Najapa Super Specialty Hospital as senior OB/GYN consultant since 2006. She was the president of Shimoga OBG Society in 2018, and she has a diploma in minimal access surgery from WLC Delhi, and she has written many health-related topics in Canada dailies. I request the chairpersons to kindly introduce Dr. Kasturi Donimat ma'am, who recently a month back. Over to you, chairpersons.
Hello, good evening, everybody. It gives me great pleasure to introduce Dr. Kasturi Donimat, who is Professor HOD, Department of Obstetrics, KMC Hubli. She is immediate past President Kasoga, and she was President Kasoga 2022. She's ex-President Hubli Dharwad OBG Society, ex-Secretary General Hubli Dharwad OBG Society, Principal Investigator for International Research Projects, MCI Inspector to colleges all over India. Undergraduate.
I think we'll go ahead with the topic.
Okay.
Okay.
Undergraduate and postgraduate examiner at many universities. Okay. Yeah, I'll tell. She has conducted Jnana Harsha Kasoga PG CME, I think for the past 6 years. And she has contributed many books. Over to you, ma'am.
Yeah, thank you. Thank you for such a nice introduction. Thank you. First of all, thanks to all the stalwarts of Kasoga, MJ Ramat sir, Nagraj sir, Dr. Vidya, and all the office bearers, Dr. I can see Rajeshwari, and thank you Hema madam, Dr. Sheila Mane madam, and very special thanks to Dr. Sneha, and all the best to you, Dr. Sneha, and thank you for inviting me to be the speaker. So we are looking forward to see you as our Vice President, Foxy. And so thank you, Shanta, for giving me this opportunity. And thank you, Shaila and Vishalakshi, for this nice introduction and for chairing the session. Now I'll just share my slides. So today I'll be talking on 1 second. Not able to move the slides. Okay, no, yeah.
Yeah,
yes, my slides are visible.
Your slides are visible, Kasturi, from the first slide. Yes.
Okay. So I made it. Okay. So So but today I'll be talking mainly on prediction and prevention. As just now all the stalwarts told that how important the preterm labor is. So it's our duty as an obstetrician to prevent this devastating scenario of preterm labor. Because as you know, a baby who is delivered preterm with very immature tissues right from head to toe is increases the morbidity and mortality to the fetus. So as all of us know, I feel my practical experience that this preterm labors are increasing day by day. What we used to see in the past, now we are seeing so many cases of preterm labors who come with just funneling, also open, membranes bulging. And whatever the evidence is, I see in a personal experience, lots of preterm labors, the incidents, threatened preterm labors are increasing day by day. And not only just preterm, so many of them come just along with preterm Pprom also. And not only the spontaneous, what we are saying is iatrogenic preterm births are also increasing, mainly because of congenital anomalies, which we are able to detect much more now compared to the past. So many small things also, and when we tell the patient, they tell no. And this thing, and other is all the medical disorders, preeclampsia, as we end up in because in order to save the mother, in order to prevent the morbidity and mortality to the mother, so many times we end up as iatrogenic preterm births. And one more is abruptio placenta. All these conditions, all the obstetric complications, the medical disorder, all these also leading to iatrogenic. So both spontaneous as well as iatrogenic preterm births are increasing day in and day out. So I'll not go into these definitions, which all of you know. I'll just directly go on to the how we are to prevent, how we are to predict, first predict and prevent preterm labors. As per WHO, now it is divided into 3 types. Extremely preterm, less than 28 weeks. Now, no longer, this is also rare. We are seeing cases who come with 26 weeks, 27 weeks, and 28 weeks. And luckily, now the NICUs are much better than what we used to have in the past. Even they are able to save 900,000 grams babies, or also our pediatrician NICU neonatalist are doing a great work, and we are able to save those babies. But at what cost? And then next is very preterm, that is 28 to 32 weeks. And moderate to late preterm, that is 32 to 37 weeks. If they're above 34, it's good. Usually the prognosis is good. Babies do well, and many of them don't even get shifted to NICU. So above 34 would be when, if it is that it lands up in preterm, but if it is above 34, it is much better. From 34 to 36 weeks plus 6 days would be much better than anything less than 34 weeks. And what are the, now let us see into what causes this preterm labors. There are some causes which are antecedent, that is contributing factors to preterm labor, that they're like early pregnancy if they have had any spotting or bleeding PV. So if you have seen any case of threatened abortion, always you should counsel those patients that in later part, these patients are prone for preterm labors. We treat them, we give them progesterone, they will continue and all. But you should counsel them regarding the risk of preterm labor after they continue also. Other lifestyle factors, as either low birth weight, low BMI, high BMI, and other addictive factors, so many things. I'll come into details. And one more thing is short interval between the pregnancies. If it is less than 18 months, those pregnancies are prone for preterm labors. And definitely, if there is a prior preterm birth, this pregnancy, you have to be careful, because most of them we have seen, if they are delivered around 32 weeks, 34 weeks, then next pregnancy also they are prone for this preterm labor. And as all of you know, infections, which I'll go into the details. Infections, all variety of infection, whether it is cervicovaginal infections, endometritis, or urinary infection. Other contributing lifestyle factors are, as I told you, cigarette smoking. And other is, I told you, other less or more BMI, both. And illicit drug use, and luckily we don't see this much. Even cigarette smoking also not much, but we do have in metro cities this problem. And both age also, very young age or advanced age, both are prone for preterm births. And low socioeconomic status, malnourishment, anemia, as stalwarts were telling, anemia is a very important cause of preterm, anemia and malnourishment. And sometimes increased fetal surveillance also, we are able to detect more and more any complications early and end up as iatrogenic preterm births. Now, what is the recurrence rate of preterm birth? If with every previous preterm birth, the next preterm birth increases by twofold. So if she had one, this time the risk is much more. Then recurrence rate ranges from 17 to 40% depending on the number of previous preterm births. If there are 2 previous preterm births, definitely almost more than 40% chance that she will have again preterm birth now. So the risk is inversely proportional to the gestational age of previous preterm birth. That is, those who have had very early births, they're more likely to have repeat preterm. Even that preterm birth also, in that, if they've had early, then again the chance is more. So the recurrence rate of preterm birth is usually after first birth, if it is more than 35 weeks, it's 5%. First birth is, if you think it is less than 34 weeks, this pregnancy having preterm birth is 16%. And first and second, both are less than 34 weeks. This pregnancy, almost more than 40% chance of having preterm birth. Now, what is this pathogenesis behind this preterm births? There are more, but mainly 4 pathological features have been described. That is, what happens here is there is premature activation of the fetal hypothalamo-pituitary adrenal axis. One is that. I'll explain it in detail. The second is exaggerated inflammatory response and infections. Now we are seeing that there is something pro-inflammatory thing that is happening in the body, which is leading to so many things. Not only preterm birth, we are seeing IUGR, oligohydramnion, and very calcified placenta. So many things because of this inflammatory response and other infection. And one more thing is abruption hemorrhage. It is a third cause. And fourth is over-distension of uterus, either due to hydramnion or multiple gestation. Again, multiple pregnancies, we are seeing more due to this IVF pregnancy, post-IVF, etc., etc. So what I was talking about, premature activation of fetal hypothalamo-pituitary adrenal axis, is whenever there's maternal stress, like hypertension, diabetes, anemia, chronic kidney disease, depression, stress, anxiety, all these factors lead to maternal hypothalamus releasing something called as corticotrophin releasing hormone. What this CRH does is, it acts on the maternal pituitary to release ACTH. And this ACTH in turn acts on the adrenal glands to release cortisol. Now what happens? This increased cortisol goes and acts on the placental CRH. That CRH acts on the fetal HPA axis, which stimulates the fetal hypothalamo-pituitary axis prematurely and releases prostaglandins. And now these prostaglandins which are released cause contractions, they cause cervical changes and other inflammatory markers which lead to something changes in the gap junctions, etc., which leads to PPRM also. So this is how this premature activation of fetal hypothalamo-pituitary axis works. Now, this activated fetal HPA axis, what it does, I told you, it releases more cortisol in the mother. That acts on the placenta. In the placenta, what happens is the DHEAS is converted into estrogen. So there is premature elevation of the estrogen levels. And this premature elevation of the estrogen levels will cause increase in the gap junctions, increase in the oxytocin receptors, which we don't want all this, because all this, and increases the activation of prostaglandins, increases the enzymes, myosin light chain kinase, etc. And all this will contribute to the premature contractions and cervical ripening, which leads to softening and effacement of the cervix. Now, one more thing I was talking, second one cause is exaggerated inflammatory response or some infection. So whenever there is some infection like asymptomatic bacteriuria or subclinical chorioamnionitis, bacterial vaginosis, trichomonas, malaria, etc., etc. These infections, what do they do? It can be some either ascending infection from lower genital tract or systemic infection, which I told, or hematogenous infections. So these infections, they produce something called as phospholipase A2, which increases the prostaglandins. And this also releases some what is called as endotoxins. These endotoxins stimulate the uterine contractions. And also I told they increase they affect the collagenase, protease, etc., which leads to degeneration of the membranes, and the membranes give away and lead to Pprom. And also this causes inflammatory response and releases prostaglandins, etc., which leads to preterm labor and Pprom. So if there is amnionitis, sometimes we see something called a sludge. Intraamniotic sludge is one of the, if you see that, that's one of the things how we can diagnose subclinical amnionitis. Then third one, as I told you, decidual hemorrhage. Whenever there is hemorrhage or abruption, it releases thrombin. That releases all the protein activated receptors, etc., leads to contractions to various mechanisms. So this is decidual hemorrhage, how it causes. Then whenever there's extensive uterine distension, so either like twins or polyhydramnios or macrosomia, this stretches the myometrium, and this, when stretching, increases the gap junctions, increases the oxytocin receptors, activates the collagenase, and leads to preterm labor. So at the end, all the mechanisms lead to one thing in common is increasing oxygen receptors, increase in the estrogen receptors, increase in the release of prostaglandins, PGF2 alpha, and withdrawal of progesterone. And all this will lead to preterm labor. So now, if we are suspecting infection, what is the role of prophylactic antibiotics? Because we told infection can cause. The evidence says that there is administration of antibiotics in women with intact membranes. There is no recommended benefit. But in clinical this thing, we see that the antibiotics do cause. So you can send the culture, vaginal swab culture, urine culture, and if culture positive, and depending upon that, you can treat. And the risk factors for preterm labor, as I told you, previous preterm labor, low socioeconomic status, teenage pregnancy, elderly, obesity, maternal history of preterm labor, undernutrition, long working hours. This is one more important, long working hours when they're pregnant. That can lead to the stress, and this smoking, cocaine, previous history of surgical method of. So you should list all that, then calculate what is the risk. What is the risk? So each one you can put one marking and then calculate how many scores. So this way you can predict clinically by the history, by the contributing factors, how much risk she has this pregnancy to have a preterm labor. So usually what symptoms do they come? Usually what they have is something, they have something like pelvic pressure, something is coming down, or something they have something like cramps, and watery vaginal discharge if they have Pprom, or low backache. So when they come with this history and do all those contributing factors which I told that list, then you should suspect or predict that this patient may go into preterm labor. Now in this pregnancy, what test you will do? One is risk factor assessment, which I told. Actually, this one table is there, like each one, family history, low socioeconomic education, all that. If you go on ticking in this risk chart, then you will know how much is this. That is on the risk assessment, risk factor. Second is the cervical measurement. Third is the biochemical markers. So the cervical measurements. So this risk factor assessment, which I have already dealt with. Then cervical measurement, very, very important to predict whether this patient is going to have preterm labor. Any short cervix. Sometimes, so this, sometimes in congenitally also they may have, but that add if they have some uterine anomalies, etc. So the strength of the os is this thing. So they will see funneling, short cervix in all those cases. So it is very, very important to assess this cervical length in pregnancy, especially if they have any risk of previous preterm labor, previous second trimester abortion and all. Or when you assess through history the risk, in all those cases also better to predict preterm labor by doing the cervical measurement. So if the cervical measurement is less than 25 mm, then the risk is very high for preterm labor. Not only cervical length measurement, and it has to be measured by transvaginal sonography. Okay. Then the other measurement for cervical is cervical consistency. So that is cervical elastography, strain elastography, and shear wave elastography. It's more of theoretical. We are not doing it. Maybe some centers may be doing. And also the measurement of uterocervical angle between the lower uterine segment and the cervical canal. If the angle is more than 105 degrees, then that predicts preterm labor, because it should be acute. If it is obtuse, if it is more, then that predicts that this patient may go in for preterm labor. Then uterine pulsatility index. Index during peak uterine contraction in women with threatened preterm labor were found to be significantly higher in women who deliver within 7 days. So this is one of the factors. Then other biochemical markers. We have so many biochemical markers, but practically we use very few of them. So the protein biomarkers in human amniotic fluid like IL-6, IL-8, IL-16, and that is CXCL10. So many of these markers are there, which have been found to be associated with increased incidence of preterm labor or preterm Pprom. But this is not routinely done. It's more in the research area. Then salivary progesterone, also when it is low, it predicts preterm birth. And one important thing which we are routinely doing is testing for asymptomatic bacteria. That is, sending a urine culture is very important during pregnancy. So culture and sensitivity, that by that we can detect asymptomatic bacteria. Then plus the one more thing is plasma urocortin. Some centers routinely are doing this plasma urocortin. With this also they are predicting preterm labor. So almost positive predictive values of 100%. So it's just a dipstick method. So it's very good, but we are not doing it, but some centers are doing this test. Then testing for cervicovaginal fluid, that is fetal fibronectin is, and one more is phosphorylated insulin-like growth factor binding protein 1. So fetal fibronectin is being done in many of the centers, especially abroad, UK, US, and all. They are routinely doing this fetal fibronectin. What they do is they take a swab from the vagina, and that swab is tested, and whether it is present or not, it's tested. And another this thing is placental alpha microglobulin. So all these are important. So I'll go into the details of this fetal fibronectin. Fetal fibronectin, as all of you know, it is secreted by amniocytes. So it something acts like a glue between the placenta, that is chorion, and the deciduum. It's something like a glue between the chorion and the deciduum. So after 24 weeks, it sees to that the chorion nicely plugs onto the deciduum, and it is adherent to the deciduum. So whenever there is little separation of this chorion from the deciduum, this fetal fibronectin leaks into the vagina. So this factor leaks into the vagina. And the ideal time to do it is between 24 to 34 weeks of gestation. Why 24 to 34 weeks is, before 24 weeks also, normally some amount of fetal fibronectin is seen in the vagina. After 34 weeks also, it is seen in the vagina. But between 24 to 34 weeks, when this snugly fits chorion onto the deciduum, this prevents the leak of fetal fibronectin into the vaginal secretion. Only when she has threatened preterm labor, when it's trying to separate, that time this fetal fibronectin leaks from the secretion of the amnion into the vagina. So that is when you can detect it. So it's not useful if you do it before 24 weeks, and it's not useful if you do after 34 weeks, because normally also in a normal patient also it may be present. So, but it is absent between 24 to 34 weeks. So this is, and if it is present, it predicts that there can be preterm labor within the next 7 days. But there are some conditions where you cannot do it. That is like if there is ruptured membranes, there is leak, you cannot do. If there is vaginal bleeding, then you can do. Then you cannot do. Or if you are putting cervical circlage, in those cases also it cannot do. Those are contraindication. Some relative contraindication is at that moment you cannot do, but you can do it after 2 days. Like if you have put a lubricant and done a PV, then you cannot take a swab for fetal fibronectin. Or if you have used some disinfectants to clean the vagina, then also. Or if there is history of coitus within 24 hours or any vaginal examination within 24 hours, then you cannot do. Then call her after 24 hours for testing. So that becomes a relative contraindication, but a definite contraindication is any PR or bleeding, etc. So this is how we can predict by risk assessment, by the history, by contributing factors. Second is by ultrasound, measuring the cervical length and uterocervical angle. And third is by biochemical markers. Now, how do you prevent this preterm labor? There are two approaches. One is primary, that is pre-pregnancy and during pregnancy. Secondary is which include when the process has started, how we will stop it. So the primary prevention is pre-pregnancy counseling is important. You should tell that she should be well prepared before she becomes pregnant. Her nutrition should be optimum. Her anemia should be corrected. Any medical disorder she has should be corrected. Any drugs which she is taking should be safe in pregnancy. So she has to switch to the safe drugs during pregnancy. So all pre-pregnancy and pre-pregnancy folate and iron deficiency, anything which is there should be all corrected. And reduce unwanted pregnancies and use contraception and reduce the space between the two pregnancies also. What you will do during pregnancy? Early booking for antenatal care, good antenatal care, and screening for risk factors during pregnancy. Secondary prevention. Secondary prevention is those who are very much prone. Then in those cases, you can put cervical cerclage or use progesterone. So offering prophylactic vaginal progesterone or prophylactic cerclage to whom? Two groups of women. If there is history of prior preterm births, less than 34 weeks, or mid-trimester loss from 16 weeks onwards, or her cervical length is 25 mm on TVS between 16 to 24 weeks. In these cases, we have to advise them prophylactic cervical cerclage as well as progesterone. And there is so many this thing now talk about transabdominal cerclage, laparoscopic or by laparotomy. So whether you do it with laparoscopy or laparotomy, it is the same. But the first preference is vaginal cerclage. Abdominal doesn't have more this thing than vaginal. Both are equally effective. Only there are certain indications where we will do abdominal cerclage, like cervix is very, very short, where you cannot put a vaginal cerclage. Or previously you put a vaginal cerclage and it has failed. In those conditions, only then abdominal cerclage is preferred. Role of cervical cerclage and progesterone in preterm labor is, as I told you, where this previous history of preterm birth, and this is a study into ACOG 2016 guidelines also. So rescue cerclage. When the membranes are bulging, then you can just put it inside with some soft balloon-like structure and then put a worm stitch. That is rescue cerclage. And what about antenatal steroids? As prophylactical, yes, definitely there is a role. Between 23 to 37 weeks who are at risk for delivery within next 7 days. When you predict that they may deliver within next 7 days, then there is a definite role for antenatal corticosteroids. Is it okay to give repeated steroids? No, absolutely no. No repeatedly every week giving steroids and all, because it will affect the brain metabolism and it can cause cerebral palsy in infants. It's not recommended. Only one dose. Benefits of antenatal steroids: it reduces the intraventricular hemorrhage, necrotizing enterocolitis, RDS, mortality in the baby. Definitely it has a role, but not for repeated doses. Mechanism of action of steroids, as all of you know, it enhances the lung architectural maturation. It increases the type 2 pneumocytes, stimulates the release of surfactant by type 2 pneumocytes, etc. So what all of you know, betamethasone, dexamethasone, I'll not go into the details. And when it is most effective, they are most effective in reducing RDS when the woman delivers after 24 hours and within 7 days after the second dose of antenatal corticosteroids. That should be the ideal timing of delivery after the steroids. Can steroid be used in diabetes? Yes, definitely. Definite, yes, you can use. Only a short-term increase in the sugar levels, but it comes back to normal. Harmful effect of steroids, as it can cause growth delay, it can affect the brain development if you give repeated doses, and sometimes can increase the maternal and neonatal sepsis risk. Now, what about tocolytics? which these are the drugs used to, I think the next speaker will be talking on that. So I'll just go in short about this. Tocolytics, which we are using commonly, is nifedipine. Patients, atosibon, which is oxytocin receptor antagonist, is good, but very expensive. Earlier, we were using lots of ritodrine, isoxaprine, terbutaline, but isoxaprine, somehow we were very happy. But nowadays, but it has taken a back seat. Indomethacin is prostaglandin inhibitor only when there is hydramnios. Hydramnios plus certain preterm, both the things are there it may help. Nitric oxide donor, nitroglycerin, some cases we used, but these patients had severe headache and lots of complaints. So I at least stopped using all this nitroglycerin. So tocolysis, there's clear role that it can be used wherever there is threatened preterm. So the RCOG recommends atosibon and nifedipine as the first line of tocolytic drugs. Nifedipine, we use 20 to 30 milligrams orally, then 10 milligrams every 20 minutes for 3 doses, then followed by 10 milligram QID or TID for a week. It's an oral route. Side effects, it causes some kind of lightheadedness, nausea, hypotension, palpitation, etc. Atosibon is much safer. It's a competitive receptor antagonist of oxytocin. It suppresses the oxytocin-mediated PGE and PGF from the residuum. Dosage is 6.75 milligram bolus IV. Then it's given by infusion. That is 6.75. It's available as 6.75 and 37.5. It's expensive, so most of the patients cannot afford this. Side effects are like same like nifedipine. And newer drugs are borosibin and rituximab. We have never used these drugs, and they have higher potency and longer duration of action. They are not available. We are not used. And we have lots of experience with isoxaprine, ritodrine, and all. They are good. They have good action, but somehow they have taken backseat after nifedipine and all. So isoxaprine used as IV infusion for 12 hours, then 10 mg IM TID, then oral tablets. Terbutaline, same IV or subcutaneous, dissolve in 500 ml RL and then give it slowly. Ritodrine, IV infusion, 50 to 100 microgram per minute. Success rate is around 75 to 80%. Side effects of beta agonists are nausea, vomiting, tremors. Yes, when you give an excess dose, all this it can cause some flushing, headache, palpitation, very rarely pulmonary edema, hypokalemia, and it can cause fetal tachycardia. So when they are on these drugs, sometimes you may get fetal tachycardia, and sometimes baby can have hypoglycemia, ketosis, etc. So contraindications you should know when not to give beta agonists. That is maternal cardiac disease. So if she is a cardiac patient or a pulmonary disease patient or hyperthyroidism, or if she is a case of uncontrolled diabetes mellitus, because it causes hyperinsulinemia like thing, so you should not use this beta 2 agonist. Magnesium sulfate as tocolytic because it modulates the calcium uptake by the cells. So it helps. It relaxes as well as in preterm, it helps as a neuroprotective, because if you are going to deliver her in the next 24 hours, you can use magnesium sulfate as a tocolytic as well as neuroprotective. So high dose 6 grams loading dose, then 2 to 6 grams per hour. Or low dose also you can do 4 gram loading dose and 2 grams per hour, 1 to 2 grams per hour. So it is both neuroprotective, it stabilizes the intracranial tone, reduces the fluctuation in cerebral blood flow, reduces the reperfusion injuries. So it really helps both as a tocolytic as neuro and also neuroprotective. Side effects, as all of you know, flushing. If you do use it in a higher dose, it can cause respiratory depression and cardiac arrest. So you should monitor this. If when you put on magnesium sulfate, these patients have to be strictly monitored for the overdosage. Contraindication, definitely, absolutely, is myasthenia gravis, relative again a cardiac disease, renal impairment, or any other. If you are using calcium channel blockers, then you are not supposed to use this. So you cannot use nifedipine and magnesium sulfate together; it can harm them. Then indomethacin, as I told you, especially if there is hydramnios and preterm labor, you can use this. Side effects of indomethacin are it can cause oligohydramnios, constriction of ductus arteriosus. Maternal are simple like gastritis, nausea, but we are worried about the fetal side effects in indomethacin. And nitroglycerin again, As I told you, some patients I had used it, but they really complained of such bad headache. I really stopped using this, and it causes tachycardia. So again, this has also taken a backseat. So when you
Hello.
Hello, we are Kasturi, you're not audible.
I think there is power cut, madam.
Oh, okay.
Yes, yes.
I think we can wait for a couple of minutes to see if that can be rectified.
Please call Kasturi and find out what is the reason.
The weather is not good, no, madam. Power cut.
Kasturi,
madam.
I lost connection in between.
Yeah.
Yeah, because current went off here. Okay, current went off, and by the time they switched on to this thing, so lost connection. I think that was my concluding slide almost. So you should. Am I audible?
Yes, ma'am.
Yes, yes.
Okay. So take home message would be like you should predict by clinical assessment and by your transvaginal ultrasound if you have facilities for biochemical markers, and then take necessary action, and wherever needed give steroids, wherever needed give antibiotics, and somehow you should try to prolong this pregnancy. Understand? So I think the next speaker will speak about the progesterones and all, because I lost the connection. I couldn't go into the details of all that. So thank you very much. Hello.
Thank you. Thank you very much, everyone. Thank you, Kasturi, for the elaborate talk on the preterm deliveries and how to prevent that. I'm wondering what next speaker, Dr. Shanta, will speak, because most of the things you have covered. So all the best for Shanta. Congratulations for the excellent talk.
Thank you. Thank you, Vishal. Yeah.
Okay.
The current is going, and there's something, it went off totally. I lost the connection. Yeah.
Okay, we'll move on with the next session. Dr. Sonia. Yeah.
Good evening, everyone. Myself, Dr. Sonia. And first of all, I would like to thank Dr. Shanta ma'am and Dr. Sneha ma'am for giving me the opportunity to be the co-convener of this webinar. Now, proceeding further with the sessions, I would like to introduce the chairpersons for the session 2, Dr. Ashwini Pai ma'am and Dr. Raksha Rao ma'am. Dr. Ashwini Pai ma'am is a professor and head of department, the Subbaiah Institute of Medical Sciences, Shimoga. She's the treasurer, Shimoga Abhijavan Society. And Dr. Raksha ma'am has already been introduced in the beginning. So over to you, Ashwini ma'am. You can carry on.
Good evening, everyone. It is my privilege to introduce Dr. Shanta Shekhar Madam. She is a very well-liked obstetrician gynecologist in Shimoga. She has done her MBBS and MD from MRMC Gulbarga, and she heads a Shanta Nursing Home in Shimoga. She was the organizing secretary of Kasoga in 2017. Her field of interest include high-risk pregnancy, infertility, and ultrasound. She's an EC member for the Southwest Zone of Kasoga for 2 years from 2023 to 25. Over to you, ma'am.
Thank you, Dr. Ashwini, for the nice introduction to me. Am I audible?
Yes, ma'am. Yes, ma'am. You're audible, ma'am.
Are my slides seen?
Yes, ma'am. Your slides are seen.
Very good evening again to all the dignitaries present here. And thanks to my chairpersons, Dr. Ashwini and Dr. Rakshara. Let me start my presentation of management of preterm labor and PPROM. Dr. Kasturi has already reduced my burden of management of preterm labor. She has spoken extensively and given us an insight into the prediction and prevention as well as in managing preterm labor as well as with PROM. All of us know that preterm labor complicates 10 to 15% of the pregnancies. Dr. Hiremat was telling that it is more than 30% of the pregnancies, and he is true. Leading cause of neonatal mortality and morbidity. We all know that delivery before 37 weeks is preterm labor, and world over 15 million births are preterm, and it contributes to 1 million neonatal deaths. In India, we take it as 28 weeks for preterm labor. We all know that mortality and morbidity increases with preterm labor. 40% of preterm labor, we say it is idiopathic. Definitely, we can find a cause if we take good history in these patients. 30% of the patients, it is because of PPROM, and about 25 to 30% now it is iatrogenic because of increasing rate of medical disorders as well as increase in the incidence of infections also. So why we are so much worried about preterm births is because it is a very serious problem, and it is a costly affair not only to the obstetricians or the team which is treating the patient, it is also for the parents, because the baby needs very much care in the intensive care, and there is increased incidence of RDS, intraventricular hemorrhage. These babies go into apnea very often. There is neck incidence more, and most we are worried about the retinopathy of the prematurity, which causes blindness in these babies. Long-term disabilities also, Dr. Kasturi told, we have mental retardation, we have cerebral palsy in these babies because they go into apnea and hypoxia very often. Chronic lung diseases are very common. There is a lot of gastrointestinal problems. Most important is vision and hearing loss. We come across many babies this way who are preterm, and there is poor neonatal neurodevelopmental outcome in these babies. We have many reasons for preterm labor. One of the important cause is previous history of preterm labor, which increases the risk by 5-fold. And also previous PROM also increases the risk by almost 30%. Maternal stress is one of the important reasons for preterm labor. And most important is uterine malformations, which we are diagnosing very much because of the 3D and 4D ultrasounds. It increases by 7-fold increase in the risk of preterm labor. Because of ART procedures, multiple pregnancies are more now, which causes polyhydramnios, and also it increases the risk for medical disorders in these babies. And delivery within 37 weeks is in 50% of the patients with multiple pregnancies. Fertility treatment also increases, as already told. Most important is when we do a second stage LSCS, it increases the risk of preterm birth by 2.5 folds. And already Dr. Kasturi told about ascending infections, which leads to PROM and increase the risk. Also nutrition of the mother, as well as younger age mothers or mothers who are more than 35 years of age, as well as increase in the risk of these mid-trimester abortions, whether they are indicated or patient go into the mid-trimester abortion, it increases the risk of preterm labor in these patients. So taking a good clinical history is very important. Already many factors are being elaborated about the risks stratification. History of cervical treatment, that is, if we do conization and cauterization of the cervix, it increases the risk of preterm labor, as well as short cervix. If we see a cervix which is very straight, it is not curved, less than 25 millimeters, on a transvaginal ultrasound, if we have to do transvaginal ultrasound, it is not a abdominal ultrasound with a filled bladder. We get a false feeling that the cervix may be normal, or we get a feeling that the cervix is having changes because of the shortening of the cervix. And genital tract infection, one of the causes of preterm labor. Most important is over-distended uterus, because there is increased risk of multiple pregnancies. We see many of the patients with diabetes. Really, I'm scared because diabetes is increasing leaps and bounds, and patients sometimes come in their mid-trimester with polyhydramnios. A lot of babies have got many of the congenital disorders which are being diagnosed, and sometimes they are being treated ex utero, and these patients have got polyhydramnios, and it increases the risk of preterm labor. We see many patients with uterine anomalies, with fibroid uterus, and acute fever. We have seen during COVID times, and now patients are having very much about viral infection. That again increases the risk of preterm labor. And urinary tract infection, even asymptomatic bacteriuria, which is very common in pregnancy, or it is patients who are with pyelonephritis. Again, it increases. As already told, iatrogenic preterm labor is very common now. So symptoms are being elaborated by ma'am. Menstrual-like cramps, we all know. Mild irregular contractions, low backache. Patients come with low backache very often in pregnancy and also in non-pregnant. There are pregnancy symptoms in the vagina and in the pelvis. Most important is patient says something is pushing my urethra while passing urea, I'm having pain, or there is pain in her thighs. And also the vaginal discharge, mucus discharge, or it is a slightly blood-stained discharge. All these histories have to be taken. If patient has got previously early pregnancy bleeding, or in mid-trimester if she has bleeding, she is at increased risk. So initial evaluation, we have to note the correct gestational age. One thing we have to know, is the patient in labor, or labor is already in the later stage and it is imminent. And in patient who comes with preterm labor, do we have to intervene or we have to wait? Is there any incidence of chorioamnitis in this patient? Are there any medical disorders? Careful history has to be taken. Also, we have to see about the cord compression. Is the patient with severe oligoamnios? Is there evidence of abruptio placenta or placenta previa? Is the patient having infection? Are there any abnormalities with our CTG? And what is the presentation of the baby? So again, reiterating the same things, initial assessment, we have to see for the gestational age, is she less than 37 weeks? We have to confirm her dates by dating scan or by anomaly scan, good clinical history, and a quick examination by ultrasonography, which has become our stethoscope now. Are the membranes ruptured? We have to see for the evidence of leaking, do a sterile speculum examination, if needed, nitrogen test or the Ferning, which we do very rarely. Now, amnisure cards are available, which predict us about the ruptured membranes. As well, we can do a ultrasonographic evaluation to see is the liquor less, and what is the presentation, position of the baby, as well as we can do a quick Doppler examination to see whether there is any maternal increased PI of the uterine arteries, or there are any fetal Doppler changes that we have to deliver the patient. And also we have to be very sure that whether the patient labor has started. Is there any evidence of infection? We have to do a quick speculum examination and see. And also we have to see her previous reports, whether she's being treated for urinary tract infection, she's being treated for candidiasis or bacterial vaginosis. Then is she having likelihood that she will deliver premature? Is the cervix normal? It is curved. Is it more than 3 centimeters, or there is shortening of cervix? And we can do fibronectin level if she is not having PROM. So after all the history and physical examination of the patient, we should do a cervical exam, per vaginal examination to see for the dilatation and effacement of the cervix. We have to be careful whether patient is having any history of PROM and also any evidence of placenta previa. Recently, I did have a patient with placenta previa. She came with slight bleeding PV and pain abdomen. And after carefully examining her, I did a very gentle per vaginal examination. She started bleeding. So we have to be very careful in these patients. And also after history physical examination, certain lab tests are indicated as well as an ultrasonography. So we have to do a quick digital examination, see whether the patient is in advanced stage of labor, and also we have to assess the baby also. What is the role of ultrasound? Already I have enumerated that. We have to see for the cardiac activity in twins, number of the babies. What is the presentation? What is the first presentation of the first baby? And also we have to prognosticate because we have to know about the fetal weight. Assess the amniotic fluid. Biophysical profile is very important when there is fetal infection, when mother is having PPROM, because we see less baby's movements as well as the respiratory movements will not be there. And quick Doppler studies help us in decision making. So coming to investigations, we have to send for complete hemogram, see for CRP when already patient comes with preterm labor or PPROM. Urine culture has to be sent as well as to see for asymptomatic bacteriuria as well as pyelonephritis. For evidence of sexually transmitted diseases, we have to take a high vaginal swab and also fetal fibronectin. If facilities are available, we don't do it in my hospital. So what is the algorithm we have to follow in preterm labor? If patient comes with symptoms of preterm labor, a sterile speculum examination, high vaginal swab if there is no leaking, or even if there is leaking, we can take a high vaginal swab. Fetal fibronectin if membranes are intact. If membranes are ruptured, we have to manage it as PPROM. Always with intact membranes, do a vaginal examination. See whether the patient is in threatened preterm labor. If the cervix is less than 1 centimeter dilated and less than 80% effaced. Is the patient in early preterm labor, that is 1 to 3 centimeter dilated and more than 80% effaced. And if she is in advanced labor, more than 3 centimeter dilated. So what are all the tocolytics which are available to us for managing preterm labor? Beta agonists, which are being used decades all over the world. Calcium channel blockers are favorite now. Magnesium sulfate is being used more for a neuroprotection than for preterm labor. Indomethacin is being used in polyhydramnios. And nitric oxide donors, that is nitroglycerin, very rarely we use it. Oxytocin receptor antagonist, atosiban, I don't have any personal experience with the drug. So tocolysis, why we use and till when we have to use. It is used in all acute preterm labor for fetal maturity so that we transfer the baby to a better NICU care if we don't have one, and for the steroids to act, for the magnesium sulfate to take care, and also to give antibiotics in the patients. There is little or no benefit for follow-on tocolysis. We can give it for 1 week or 2 weeks, not throughout the pregnancy. What is the efficacy of tocolytics? It is delays the delivery for more than 48 hours in 90% of the patients against with 50% if no tocolysis is used, for a period of 1 week for 60 to 70% against 40%, and for more than 37 weeks, we are not going to use tocolytics. Important drug difenhidramine is a calcium channel blocker which inhibits the influx of calcium, which is necessary in the second phase of action potential for the uterine muscle. Initial dose is 20 milligrams orally. Every 30 minutes, we give it until the uterine contraction stops, and maintenance dose is 10 to 20 milligrams every 4 hours. The maximum dose of the tocolytics is 160 milligrams in 24 hours. It is safe, quite effective drug in prolonging preterm labor with minimum maternal and the neonatal side effects. Most important is it eliminates the need for intensive maternal monitoring, which is required in beta mimetics. Important side effects is headache, hypotension, flushing, tachycardia, and these usually subsides in 1 to 2 days. Most important cardiac contraindication is in cardiac disease. If there is renal impairment, we have to reduce the dose. Maternal hypotension, and if it is used, to be used cautiously when we use nifedipine with magnesium sulfate. Most important is tocolytics is beta adrenergic receptor agonist, which were used extensively throughout the years. It is a smooth muscle relaxant which acts on the beta-2 receptors, inhibits the myosin light chain kinase action. Isosuprene is extensively used. Ritodrine I have not used, no personal experience, and terbutaline I don't think I have used it. Contraindications for this is maternal cardiac disease, uncontrollable diabetes because it increases the diabetic state of the mother, and hyperthyroidism. Isosuprene is a commonly used drug nowadays. It is not being used much. Potent vasodilator, so we have to be very careful when we use it in patients with anemia, hypotension patients, and it is approved by DCGI in our country. ACOG nowadays recommends also as a first line of treatment, can be used for maintenance therapy for a few days. It is used, already madam has told, as IV infusion. We dilute 4 ampules to 6 ampules in 500 ml of 5% dextrose. It is given in a infusion rate of 0.2 to 0.5 milligram per minute and adjusted as the patient responds. In a dose of 30 to 45 drops, it is started. We have to monitor extensively for blood pressure and pulse rate. If the blood pressure is less than 100, pulse rate is more than 120, we need to titrate the dose. The side effect is important is hypotension, headache, palpitation, tachycardia. Sometimes it's pulmonary edema if we use it in PH patients, as well as cardiac failure. Terbutaline is used nowadays, I think less. It is given IV as well as subcutaneous. Definitely it reduces the chance of preterm birth in 48 hours up till 7 days, but it is not given up till 37 weeks or so. Important is it causes hypotension, tachycardia, tremors, and arrhythmias in the mother, fetal tachycardia, and neonatal hypoglycemia. Atosiban, which is oxytocin receptor antagonist, studies have shown that it is superior to other tocolytics. As Dr. Kasturi told, it is an expensive drug and it is administered in a bolus, 6.25 milligrams over 1 minute, followed by continuous infusion. Side effects are nausea, dizziness, headache, and flushing. I don't have personal experience using this drug. Prostaglandin synthetase inhibitors, we use very rarely indomethacin in our country. Ketorolac, I don't have personal experience, and Sulindac is being used in UK. It is not available in India. It is used mostly in patients who are having severe polyhydramnios because it decreases the amniotic fluid. The side effect of the drug, which causes constriction of the ductus arteriosus and oligoamnios. It has to be used less than 32 weeks. After 32 weeks, we are not supposed to use it. Initial dose is 25 to 50 milligrams orally. followed by 25 milligrams every 4 to 6 hours to be used only for short period of 3 days. Maximum dose is 200 milligrams. Side effect of the drug is heartburn, GI bleeding, thrombocytopenia, and asthma. We are not supposed to use in asthma patients. Also contraindicated in renal and hepatic impairment, and also if patient is having coagulation disorders and thrombocytopenia. Magnesium sulfate, all of us have got extensive experience using this drug. Mainly it is used as a neuroprotection drug, less than 32 weeks. Rarely it is also used as tocolytic. It is a calcium antagonist, so be careful when we use it with nifedipine, cleared by renal excretion. We all know it is given as loading dose of 4 to 6 grams, diluted, loading dose as IV, infusion over 5 to 10 minutes, and we continue it as 1 to 2 grams per hour, continuous infusion. Now we can give it in infusion syringes. The therapeutic range is 4 to 7 milliequivalents per liter. We get complications if it increases to 10 milliequivalents or more. So we lose deep tendon reflexes. We have to monitor the patient. There can be respiratory arrest and cardiac arrest if it is more than 12 to 25 milliequivalent, 12 to 15 milliequivalents per liter. Side effect, we all know, warmth and flushing. It occurs in the patient. Most important is respiratory arrest and cardiac arrest. Fetal hypotonia is seen, but the baby is okay, but we see fetal hypotonia because it decreases the calcium levels in the baby. So all of the major side effects I have discussed already with you all. So the mainstay of the treatment in preterm labor and PPROM is corticosteroids, which reduces the morbidity and mortality significantly in the preterm babies. It reduces the incidence of RDS, intracranial hemorrhage, stimulate the pneumocyte 2 cells, so to produce surfactant, statistically significant if it is given less than 34 weeks. Rescue dose is given if the pregnancy prolongs more than 2 weeks and if the patient is less than 34 weeks. Betamethasone already discussed, 2 doses, 12 milligrams IM, 24 hours apart, which is used extensively few years back. Now we are using dexamethasone, 6 milligrams, 12 hourly, 4 doses. Corticosteroids are very beneficial when the delivery occurs at least 48 hours after the first dose. Antibiotics are indicated if the pregnancy is less than 30 to 32 weeks, and if the patient is having PPROM with antibiotic prophylaxis. It is also given in patients with Group B streptococcal infection. We usually start with ampicillin 1 to 2 grams every 4 to 6 hours for 48 hours. Infusion as a IV dose, and we give with that 1 gram of azithromycin for 5 days. And after 2 days, we follow this with ampicillin or amoxicillin orally, 500 milligrams every 8th hourly for 5 days to 7 days. If patient is having penicillin allergy, we can give clindamycin 600 milligrams orally 3 times a day. Avoid amoxiclav because it causes necrotizing enterocolitis. Few studies have come up that way. There is definitely role for emergency cerclage with the patient with preterm labor 24 to 34 weeks without PROM. If the cervix is dilated, we see membranes projecting outside. We do emergency cerclage, but it is less effective against the prophylactic cerclage we do it in early pregnancy. There is increased possibility during the PROM, the rupture of membranes during the procedure or after the procedure. We have to rule out infections, contractions have to be subsided before we do a stitch, and also we have to rule out rupture of membranes. Addition of antibiotics and tocolytics definitely increases the efficiency. We can do either modified McDonald's procedure or a worm procedure in these patients. But definitely we do so many rescue cerclages, but patient goes into PROM within on the table or within 1 to 2 days. Coming to PPROM, why we are worried about PPROM is because of the infection. We have to prevent that. We have to enhance the lung maturity in these babies. We have to continue the pregnancy safely in the uterus. Already we know that mother's womb is better incubator for these babies. Whether it is a preterm labor or PROM, we have to continue the pregnancy as much as possible, closely monitor the patient with hemogram and CRP, serial ultrasonography definitely every week, and Doppler studies and continuous CTG. It is better if patient comes with PROM very early in pregnancy, we keep the CTG machine in her room, and whenever required, we do a CTG and see. Even the patient also is comfortable and we are also comfortable if there is a reactive CTG. So how we are going to decide the patients with preterm labor and PROM? Why we want to wait? We want to wait because we want to establish the fetal maturity. We want the corticosteroids to be effective. We want a good antibiotic cover. If our NICU facility is not available that much, or we want patient also wants and they are affordable, we want to transfer to a level 2, level 3 NICU. We want to shift the patient. It is better we prevent the delivery at least around 48 hours. And we want the patient to continue the pregnancy and the nature take its own course. When we want to intervene, it is with the onset of labor. If there are any acute complications, like patient has got fever, there is chorioamnionitis, or there is cord compression, or there is cord prolapse. If the patient has got bleeding PV, be it because of placenta previa, or it is because of abruptio placenta. If the baby has got infection, or if the mother have got infection, or is there any maternal or fetal compromise, we want to intervene. So managing the babies with preterm or with PPROM depends on one, gestational age and availability of our NICU facilities. What is the fetal presentation? And what is the fetal heart rate pattern? Is there any evidence of maternal or fetal distress? Is she in labor? Is she in advanced labor? What is the cervical assessment? Definitely all of us know that cesarean does not improve the neonatal outcome in these babies. Counseling the patient with pre-PROM or with preterm labor, it is a teamwork. It involves all the faculty in whatever is available in our setup. We require obstetricians, 1 or 2. We require neonatologists. We require physician. We want endocrinologists now because a lot of patients are there with diabetes mellitus. Also with PIH, we see alternate patients with diabetes. Really, we are all scared of diabetes in our country, and we need a good nursing staff. They really play a role in the management of the mother, counseling the mother because they are with the mother 24/7. We sometimes go only for rounds. And also they take care of our babies in NICU. And also with all these people, counseling with a team, with the parents and their relatives is very important because of the good neonatal outcome. Because we keep babies in NICU for days together. Sometimes it is 1 month, 2 months. Sometimes we don't get good results. And a very well motivated parents definitely help us in managing these babies better. So care is also required in labor. Electronic fetal monitoring throughout the labor is very important. Antibiotic cover, definitely we do. No instrumental delivery, especially the ventouse not to be applied. Neonatologist has to be present at delivery. And what are the indications for cesarean section? If the first baby is abnormal presentation in twins, or if the baby is in transverse lie in a singleton, or if the baby is in breech presentation, what are any acute complications before the onset of labor or during the labor? If there is failure to progress of labor, Definitely, cesarean is not very easy in these babies because the lower segment is not very well formed. We have lot of extensions because lower segment is not formed. We have lot of bleeding. It requires expertise in doing cesarean in a low birth weight babies, and it requires adequate abdominal incision. We require a lower segment approach, which we do not get in all the patients. Extensions should be done. Incision have to be extended with scissors upwards like J-shaped incisions. And if it is non-vertex, it has to be gently delivered as breech. And preferably if some amniotic fluid is there, it will help us in delivery. So after speaking about the preterm labor management and PPROM, I will present a case of PPROM which was in my hospital for about 11 weeks. She was admitted, Mrs. D was admitted at 24 weeks of pregnancy with leaking PV. She is gravid to abortion 1. Patient is a case of GDM on insulin. She was on low molecular weight heparin, 40 IU, because she had previously an abortion at 22 weeks with abruptio placenta, and her APTT was a bit more. Otherwise, all the other parameters were normal, and now she was with mild PIH. She was admitted on 28/2/23. She stayed till 15/5/23, almost more than 2.5 months. She is 25 years old lady with 4 years of married life. The first pregnancy, I treated her for PCOS, and ovulation induction drug was done. Ovulation induction was done. She had abruptio placenta at 22 weeks. She came at midnight with bleeding PV. 4 months after her abruptio, she was already put on a higher dose of folic acid, and with glycomed, she came with spontaneous pregnancy at 8 weeks of gestation. And I put her on low molecular weight heparin at that time with her ecosprin 150 milligrams. She was admitted on 28th of February with leaking PV. She already was on insulin, and we admitted her and adjusted her insulin dose according to her GRBS, which was done 8th hourly. She was on nifedipine 10 milligrams OD, and dose was adjusted according to her blood pressure, low molecular weight heparin till her delivery. IV antibiotics was given for 1 week. She was treated with urinary tract infection with nitroglycerine. Weekly, I gave her progesterone injections, the long-acting ones. Steroids were started at 24 weeks only. I had discussed with the patient about the complications and all. And it was repeated every 2 weeks because she was with diabetes, and I was not comfortable less than 32 weeks. And magnesium sulfate was given, started after 28 weeks for neuroprotection. Also, I gave her SOS for tocolysis also because she was already with PIH, preeclampsia, with the blood pressure of 140, 100, sometimes 110. I started her on magnesium sulfate whenever I wanted tocolysis also, and also for her PIH condition. Eventually, because of her severe PIH, and she already had about 34 weeks of pregnancy, I did an elective LSCS because the SOS was not dilated. She delivered a live baby, 3 kg, and baby was in NICU for 1 day. Not much hypoglycemia in the baby. It was with only one single surface phototherapy for 1 day. Post-operatively, after 24 hours, I started her on low molecular weight heparin, and we gave it for 1 week. She stayed 1 week after the delivery. We continued her antihypertensive for a period of 1.5 months. And totally, this patient stayed for 11 weeks in my hospital. A very well-motivated patients. They were really poor, and only her mother and her husband took care of her the whole 11 weeks. So I want to tell about my pregnancy also. I had PROM at 31 weeks. I was admitted with my teachers, Dr. Nishti madam and Dr. Banale madam. They really took care of me, and I was started on antibiotics. Then madam gave me ampicillin 2 grams and followed by my oral antibiotics for 1 week. And then she gave magnesium sulfate because I went into hypotension with isoxaprine, and she gave then magnesium sulfate for 1 day. And then I was given steroids, and then they waited for 2 to 3 days. I was having continuously uterine action, and already I had progressed to 2 centimeter dilatation. Then they decided, let us allow her to go into labor. Once they stopped all the interventions, even my labor pain stopped. And I was admitted for 2 weeks, and I went home. I delivered at 37 weeks of my pregnancy. And really, my teachers took care of me. And after delivery, as anticipated, my son went into septicemia and hyperbilirubinemia. I was with him with IV antibiotics and with phototherapy. Again, I was in the hospital for 15 days. Now he's 29 years old. He's an obstetrician himself. So he had septicemia because I had PPROM very long. My teachers, pediatricians, they took care of me and my baby. So it was a good ending for me. But every time we don't have very good outcome in these patients with pre-PROM and preterm labor. We keep in ICU babies for long, for 1 month, 2 months, and then they don't have results. Definitely, as we are worried, even the attenders become irritable, and so many patients, they go to court. We all know that. So my take-home message is definitely preterm birth is preventable problem. We have to counsel the patients. It is before the pregnancy. We have to take good history, vigilant monitoring in these patients, and aggressive treatment definitely will help us to give a carry home baby for these mothers. Definitely, the womb is the better incubator for these babies. Progesterone definitely has got a role in its prevention as well as in treatment. Tocolysis important in preterm labor. Steroid administration is very vital. Magnesium sulfate for neuroprotection, as well as in patients who are having severe PIH, definitely it will act as a tocolytic also. It will prevent complications with PIH also. Cervical cerclage judiciously, if it is used, definitely it has got a role. I thank you very much for your patient hearing, and I thank my chairpersons as well as our Kasoga, Dr. Sneha Bhuyar ma'am also, and again wish her a very her to be our vice president, and also wish her in her future endeavors also. Thank you very much.
Thank you so much, madam. Thank you for your best wishes and all your support. Thank you.
Thank you.
And
Thank you, ma'am.
thanks for the wonderful presentation as well. Congratulations.
Nice presentation, Shanta. Very nice.
Thank you.
Thank you.
Thank you, Shanta ma'am. That was a very elaborate and a very extensive discussion regarding management of preterm labor with a very nice personal touch. So it was very systematic. I really like the way you went through the whole discussion in a very systematic manner. And I'm sure all of us here are now very well motivated to manage all the preterms we do get in our day-to-day practice. It was a very nice discussion today, ma'am. Thank you so much.
Thank you.
Shanta ma'am. We all know that a pregnancy ending with either a preterm birth and with the baby in the nursery can be very overwhelming for both the parents as well as the caregivers. And the true strength of a premature baby's fighting spirit can never be measured by either the weight of the baby, length, or the gestational age. And there needs to be a very constant dialogue between the nursery team, the pediatrician, the obstetrician, and the parents as well. So with the main take-home messages being first, try to prevent the onset of preterm labor, and if the preterm labor has already set in, then try to arrest it if there are no contraindications, and based on individualization and guidelines, manage the preterm labor well and make sure that there is effective neonatal care. So with these key points, let's move over to the last aspect of this webinar. That is the panel discussion on preterm labor and PPROM by moderator Dr. Sneha Bhuyar ma'am, who has come to us with a request for her vice president candidature from the West Zone for Foxy, and wishing her all the best. I take the privilege of introducing all the panelists of today's webinar. We have Dr. Sri Lakshmi from Shimoga OBG Society, a very dynamic academician with one fellowship in medical genetics, and she has been the professor and HOD at Subaya Medical College, and at present is a consultant in fetal medicine at Malnad High Tech Diagnostic Center. And she's been the executive member of Kasoga and a national corresponding editor of Jogi. A very warm welcome to you, Dr. Sri Lakshmi ma'am. And we have Secretary of OBG Society, Dr. Sonia Batra, who is the Chief Consultant OB-GYN and Laparoscopic Surgeon at Ashoka Sanjeevani Hospital, Shimoga. She is the Honorary Secretary of Endoscopic Committee, Kasoga, and at present the Secretary of Shimoga OB-GYN Society. She has various achievements: the best paper publication in Foxy, 5 gold medals, the most prestigious awarded by former President of India Abdul Kalam himself. And she has a YouTube channel, gynecologist Dr. Sonia, and takes pleasure in spreading awareness on OB-GYN myths in the society. Next panelist is Dr. Sushma HP, who is from Hassan OB-GYN Society. She is the secretary there, and she at present is a consultant at MMM HRC Hassan. She has the best postgraduate paper award at Mesocon 2020. Publications in international journals, JMSCR and Indian Journal of Case Reports. She is a member of Emergency Obstetrics and Critical Care Committee of Kasoga 2023-25. Welcome to you, ma'am. And
thank you, ma'am.
Next panelist is Dr. Sheila Lohit, who is from Chikmagalur Obstetric Gynec Society. She is a dedicated and caring gynecologist with 8+ years of experience in clinical board, certified with high-risk obstetrics, gynecology, laparoscopic, and infertility surgery. At present, she is working at Sanjeevani Hospital, Mahalakshmi Layout, Bangalore. And a very warm welcome to you, ma'am. Our next panelist is Dr. Pandurangaya. He is the assistant professor at Chikmagaluru Institute of Medical Science. He is an alumni of SNMC Bagalkot and has DNB from Edappal, Kerala. He is the chair of the organizing committee of AKCOG 2022 and holds special interest in high-risk obstetrics, urogynecology, endoscopy, and infertility, and has more than 30 research articles published in national and international journals. Then our last panelist is Dr. Hema Mohan. She is a very dynamic member of Shimoga OBG Society and an associate professor at Department of OBG at SIMS. And she has been the organizing secretary of Kasoga 2017. So I heartily welcome all the panelists and the moderator. And I also request Secretary Kasoga, Dr. Rajeshri Paladi ma'am, to be the expert in this panel discussion. So over to you, Sneha ma'am.
Yes.
Kindly take over.
A very good evening to all of you. At the outset, I would like to thank all the stalwarts from Kasoga, respected Dr. M.G. Hiramat, Dr. Nagaraj, and Dr. Hema Divakar madam, and Dr. Sheila Mane, and of course the team Kasoga, Dr. Vidyatabi, my dear friend, as president, Dr. Rajeshri Paladi, welcome as expert for the panel, and of course Dr. Suman Gaddi, who is the treasurer of Kasoga, and I thank heartily and congratulate Dr. Shanta Shekhar for being the wonderful convener, and of course Dr. Sonia and Dr. Raksha for doing a wonderful job. So I take this opportunity to welcome all my panelists whom you have already introduced, and without much ado, I straightway go to the panel discussions. I'm sure all of you know this person, a very well-known figure, Albert Einstein. Yes, famous personality, premier ones, the Picasso, the Napoleon, Steve Wonder, and me. Is this always so? No. Dr. Shanta, you have heard her talk. Yes, though you can sell through in majority of the times, maybe if you have the facilities available, and of course, you have the appropriate and timely intervention, definitely you can sell through, but it's not always so. And that's the very reason there comes the role of prediction and screening, and of course prevention wherever possible and not contraindication, and of course the active management per se, or if not so, then the in utero transfer. So with this, I take you all through the, a case, I would say case-based scenarios where we all are here to discuss and learn, including me. So Dr. Sonia, Sushma, Pandurangaya, Dr. Sheila, Sri Lakshmi, and Dr. Hema, I welcome all of you. So if you have a look at the statistics of WHO, that is in 2018, every year, an estimated 15 million babies are about preterm. And because of these preterm deliveries, you have almost 1 million of deaths, which are, under 5. That high is the mortality rate for these babies under 5. India contributes to the maximum, that it tops the list of first 10 countries in the world who are, we got high incidence of preterm labor, and it tops the list where you have the perinatal mortality contributing to 3.5 million per year. So 3/4 of these deaths, they could have been prevented with the current cost-effective interventions, what we have already heard about and we're going to discuss. So across 184 countries, the rate of preterm ranges from 5 to 8% of babies. So now we go straightway to our panel discussion, and I start with this first case. You have this 28-year-old primary gravida with 31.5 weeks of gestation. She presented to you at the casualty at 3 a.m. with complaints of mild abdominal pain. When you examine the vitals, the pulse rate is good, 88 beats per minute. Blood pressure is slightly higher, 120 but 90. Uterus is 32 weeks, irritable, and fetal heart is good. The cervix is posterior. External os admits tip of finger, cervix is short, and there is no show or leak. What is your diagnosis, and how will you go ahead with the management? We start with the first panelist, and let us go ahead with the case discussion here. Hello. I request all the panelists to be ready. Dr. Sushma, Dr.
Yes,
Shisha, yeah. So can you please can anyone take this case?
This is a case of threatened preterm labor. Since the cervix is not yet dilated, ma'am, so we need not put rescue cerclage. We should just relax the uterus by giving nifedipine. Nifedipine 20 mg stat followed by 10 mg TID.
My first question, I'm sorry to interrupt you here. At 31.5 weeks, do we have any chance to go for cervical cerclage? Should we go for cervical cerclage?
Ma'am, definitely if there is a cervical if cervical dilatation is there, then I would recommend cervical encerclage, ma'am. Since this is not a high risk pregnancy for
okay, so my next question is what gestational age you can put the stitch, or any time up to term?
Hello.
Till what gestational age you would like to put the stitch, cervical encerclage? Till what gestational age?
Any time up to 34 weeks, ma'am.
Hello.
Hello.
Hello. Can anybody?
Can you hear me?
I think I'm not getting your voice. I'm not getting your voice. Can you please say that? Up to what period of gestation you can put a cervical?
Hello.
Some network issues, I think.
Hello.
Hello. Hello.
Hello, madam.
Yeah, can
Your voice is breaking.
can you see me?
No, ma'am.
You cannot see me?
We can hear you. We can't see you.
Can't see you, madam.
Yeah. So can you see the presentation, or do I need to? Yeah, you can see my presentation, right?
No, madam.
No, madam.
I can see that it is. Now, can you see me? Hello.
No, madam. No, madam.
We can see you, ma'am.
Hello.
Yeah, we can see you.
Yeah, now we can see.
So there's some network issue, I think. So I will reshare once again my presentation. Yeah. Can you see the presentation now?
Yeah,
Yes.
madam. Yeah.
Yes. So is it full screen?
Yes.
Okay. So the first, this is the case where you have the gestational age as 31.5 weeks. Okay. So these are the findings where you don't have cervix is dilated and it is not even, it's only short cervix, it is not dilated. But 31.5 weeks of gestation, do we do the cerclage at this gestational age?
No, ma'am.
Yeah,
No, no.
anybody can, can take up this discussion ahead. So yes, Dr. Srisha, Dr. Sushma,
Yes,
and
ma'am.
Dr. Pandurangaya. Can you take up this discussion ahead?
Madam, madam, this is Pandurangaya. This patient is 31.5 weeks, madam. And moreover, if you see we have to classify this patient whether it is a preterm labor or not. Initially, we will go with the contractions, madam. So patient is a little bit of irritable uterus is there. So if it is more contractions is more than 6 or anything more than an hour, and also we will take it as for the preterm labor. And the next step we will go with the dilatation.
So here the findings are very clear. The uterus is just irritable. Okay, the uterus is just irritable. You don't have frank contraction, and the cervix is also not dilated. So basically, is she in preterm labor? That is what the question is.
No, madam. First of all, she is not in preterm labor because contractions is not not as mentioned because it's only irritable, and also cervix dilation should be more than 2 centimeters to tell that it's preterm labor.
Yes.
And
so what is your diagnosis? So what is your diagnosis?
So we have to go with whether
not established preterm labor. She is not a case of preterm. So it is a threatened preterm labor, right?
Yes, madam.
Okay. Now you can talk about what will be your approach. What investigations would you like to send for this patient, and what will be your way of management? Yes.
Madam, first I will go with blood investigations like CBC and C-reactive protein, madam.
Okay. Whether she has any infection. Yes.
To rule out any infections are there or not.
Correct.
And then next I will go with to see the patients and the contractions, anything. So we will go with NST, madam.
Yes.
Then to see the status of the fetus and the liquor and the weight of the fetus and gestational age, I will go with the ultrasound, madam.
Okay. Okay,
And
so everything is fine. She is in threatened preterm labor. Now, how do you manage this patient? Because you want to pull her to 34 weeks at least. So how do you want to manage this patient now? What treatment?
So
any role for bed rest? Any role for tocolysis? How do you think about all this?
So mainly she is 31 weeks, madam. So I need, suppose if she go for the labor, I need her to be at least baby for the, not for going for the distress of the baby. So I will use corticosteroids, madam, initially.
Okay.
So I will start with the betamethasone 12 milligram for about 2 doses, 24 hours apart.
Okay.
And then I will see for whether she is having any infections is there or anything not. If any is there, I will start with the antibiotics. So at least for then 48 hours to 72 hours, I will go with a relaxant, that is tocolysis.
Okay, tocolysis, yes.
Tocolysis with a nifedipine, madam.
Okay, okay. Any role of progesterone you have here?
Yeah.
Use progesterone.
Yes, madam.
And what is the preferred route for this? Yeah.
Madam, mainly the progesterone. We can use the progesterone like 17-hydroxyprogesterone. Otherwise, we can use the vaginal micronized progesterones, madam.
Okay, okay. So any comment on the bed rest or reducing stress? Yes.
So usually I won't advise a complete bed rest. She said she should be taking from the, if she is working or any strenuous work, such things she should avoid.
Yes.
And only thing is we want household things she can be going.
Okay.
Routine works.
Yeah. So she has to avoid strenuous work like lifting heavy weights and bending and, or for pushing forcefully something, or, if she's training at school and all these things, she has to avoid. And then, yes, she has to maintain her good hydration as well as good hygiene, as you have said. And definitely, if at all she has any infection, you have to treat her. So this is the basic case. We just want to, plan her out that if at all you find a case of threatened preterm labor, you would like to manage her this way. So as you have rightly pointed out that because she doesn't have strong contractions, maybe you will just use some tocolysis to work it for 48 to 72 hours max, so that your corticosteroids work for good fetal lung maturity. But if at all she has contractions and what all, we'll see in the next case. So now, Sri Lakshmi, the next panelist, I think, can take up this case. You have this 38 years. Hello. Yeah, you are this 38-year-old third gravida with previous 2 normal deliveries, full-term normal deliveries. Now this time she has, diabetes, and she comes to you with the diagnosed polyhydramnios, and she starts getting mild abdominal pain. When you examine, her vitals are good. Other systems are also okay, no problem. Uterus is 28 to 30 weeks. When she is 26 weeks by dates, uterus is 30 weeks over distended, and she's got contractions, 2 contractions in 10 minutes, almost 15 to 20 seconds duration. Fetal heart is good. Cervix is now dilated 2 centimeters, 60% effaced, and membranes are present, but the station is high. What is your diagnosis and how will you manage this case?
Hello, ma'am. Good evening.
Yeah, good evening.
My case has the risk factors of 38 years and diabetes, and also has polyhydramnios, suggesting it is an uncontrolled diabetes.
Yeah.
So my the first is I would like to complete the history. That is abdominal pain she has. Maybe she has associated urinary tract infection, and even there is a bacterial vaginosis as well. But here speculum examination, I would like to reconfirm whether there is a white discharge as well. And sent for urine microscopy, and would like to know what about the diabetes, fasting, and a postprandial blood sugar. Urine ketones are very important here.
Yes.
So with all these three completing this, I would like to do this examination findings. Would like to do the speculum examination is important here, and take a high vaginal swab as well, sent for culture sensitivity. Now with this 2 centimeter dilated and 50% effaced with previous 2 normal vaginal delivery and having contractions, I would like to monitor for uterine contractions whether she is in preterm labor, because 50%
that we have already told you that she's got 2 contractions in 10 minutes.
Yes.
So they are very significant. 15 to 20 seconds almost.
Yes.
Okay. Yeah.
So now comes the role of
and you have the cervical changes as well. Okay.
Yes.
So now first is offering the admission to the patient, explain the prognosis and know the ultrasound estimated fetal weight and the presentation as well. Because she is a multigravida, chances of malpresentation is also present. So after doing ultrasound, now I would like to offer admission to the patient. Second one is my consultation with and a counseling with an NICU neonatologist and a word with a physician to know the content of the blood, the diabetes status, and now the role of tocolysis, steroids, and magnesium sulfate comes in role. Tocolysis, yes, diabetes plays a very important role, and we need to take it in mind when we are asking for tocolysis and for steroids. Tocolytic, always nifedipine is the best choice. And 20 milligrams stat followed by 10 milligram thrice a day, or even we can offer for a nitroglycerin patch as well. Steroids depends upon whether the choice of steroids, whether to go for a betamethasone or dexamethasone, depends upon her diabetes control. If
How do you advise in this patient? You know that she is diabetic already.
Yes,
so
yes.
What
So
what
if
steroids
her
you use?
diabetes is under good control, then I would like to always prefer betamethasone 12 milligrams 24 hours apart. But if it is uncontrolled diabetes, then I would like to prefer a dexamethasone 6 milligram 12 hourly 4 doses.
Yeah,
So,
but is it not so that whatever steroids you use, there is a little change in the sugar levels, and you may have to control it once a day?
definitely. That is why I have offered admission and also taken a word with a physician, because I am very well aware that there will be change of sugars and I need to monitor. There will be change of higher doses of insulin are required at present now. With this now, if at all, if she she is 30 weeks plus, and if it is not under by 4 hours or 6 hours, I will be able to reassess. If she goes into established preterm labor and assuming it is a cephalic presentation, then I even offer.
Do you wait for 4 to 6 hours for this patient? Already she's got membranes and the station high up, and you have 2 centimeter dilated, almost 60% effaced cervix. Do you wait for this patient to go into the established preterm labor, or how?
No, as such a multigravida, that too in a preterm labor, definitely I would expect her to deliver. But if I get time, I definitely would like to offer magnesium sulfate for neuroprotection. And if urine culture and your microscopy.
Before that, what tocolysis you will use for this? Is it only nifedipine, or you would like to try atosiban for her?
Yes, ma'am.
She's multigravida. Her labor will be short, right?
Yeah, yes. Atosiban definitely has a good choice if available and can be done. This is a good choice actually. So first start with the nifedipine and also nitroglycerin patch. If not working, or if she is already getting more and more contraction, yes, within an hour, would like to start with atosiban.
Yeah. So this question actually has been discussed by you only. What are the risk factors for this lady? Her age, her multiparity, and presence of polyhydramnios we already discussed. So Dr. Sushma, we have, how do you classify these risk factors as far as the levels of uterus, cervix, and the baby is concerned? What can be the possible mechanism? Dr. Sushma, you can take up this case, this question. Do we have Dr. Sushma here? No. Okay, you can continue, I think, Dr. Srilakshmi.
Yes, ma'am. So when we classify the risk factors of preterm labor, I would like to classify as whether it can be preventable or non-preventable, or otherwise it can be like a modifiable risk factors or non-modifiable risk factors. So going from the left-hand side to the right hand side. Infection, yes, definitely modifiable, preventable, and treatable. Vascular disorders is, yes, it is a basket of many disorders. Yes, I have a definitely
Dr. Sonia,
may or may not be.
Mechanism wise you have discussed. To Dr. Sonia, I would like to ask you, what are the risk factors clinically? Why our ladies at risk of preterm labor? What are the other risk factors as far as the age and the clinical, the maternal characteristics, we would say?
Ma'am, because in India, most of the low socioeconomic status is annual low nutrition, because we don't treat ourselves after marriage. I have seen the ladies start thinking more about the children and husband, and they don't take much care of themselves, and they're not taking nutritious food. So nutritional deficiency, anemia, low socioeconomic status, and when the people are working, the advanced maternal age, along with the stressful factors at work. These are also the factors. In our case, is the diabetes mellitus, then it's polyhydramnios, which is also the factor for preterm labor. Apart from that, infections can also be there, because white
What do
discharge
you
or
think
vaginal
now,
discharge.
this patient? I think lots of noise from Saiti, can you please mute others who are not the panelists? Yeah, please, for a while. So, Dr. Sheila, do we have Dr. Sheila Lohita? Do we have Dr. Sheila? Can you please unmute yourself? Do we have Dr. Sheila? Can you please put on your video? No, we don't have. Dr. Hema Mohan, do we have Dr. Hema?
Yes, ma'am. Yes, I'm here, madam.
Yeah. So for this patient, Dr. Hema, what do you feel that 2 centimeter dilated and this case? What do you feel that your management should be?
Madam, preferably because she is a diabetic, she might end up in a preterm labor within few things. So, first of all, I'll put her on tocolytics, madam, preferably a calcium channel blocker.
Yes.
Then followed by, to accelerate the lung maturity with a caution, I prefer either betamethasone or the dexamethasone. But the recent studies, both of them have a good efficacy now. So I prefer dexamethasone with a dosage of 6 milligram per 12 hours for 4 doses, madam. Usually the dosage of this, the action of these steroids starts within 24 hours. So even a single dose of steroids will be helpful for the fetus to accelerate the fetal lung maturity.
Okay, perfect. What do you not think about the magnesium sulfate for neuroprotection for this baby?
Yeah, magnesium sulfate also I would like to add for the neuroprotection, fetal neuroprotection, madam.
Okay. So just to, you have very well covered the case management as such. You will not put a stitch here. That is for sure. You will manage her conservatively. Definitely you will control her diabetes. I mean, that goes on simultaneously. That goes without saying. You will monitor the mother as well as fetal condition, and then you will meanwhile try to relax her uterus by giving tocolytics, and you will prepare the fetus if at all if the things work. Well and good. If at all she lands up into preterm labor, then of course you have to keep everything. So I was talking about the risk factors of preterm labor, where a woman who has got a previous preterm birth is at a very high risk of preterm labor once again, irrespective of her present care. Extremes of age, assisted reproduction, fetal fibronectin if it is positive, and as you said, the high level of stress and cigarette smoking, of course, short cervical length, the various genitourinary infections, low socioeconomic status, and of course the high or low BMI, extremes of BMI and multiple gestation. And in addition to this, the women who never come for antenatal care, who develop preterm PROM, women who have got uterine anomalies, chronic or acute conditions, and of course the surgical procedures on cervix like conization and amputation, all this, they put the patient or the woman at a high risk for preterm birth. So that is what the discussion is. Now, what is the plan for this? What investigations you will ask for this lady, and what medical treatment you will carry out? We have discussed this, that you said that you will hospitalize this lady. You will if at all you don't have the facilities, you will start her on tocolysis, maybe the first dose of corticosteroids and magnesium sulfate if possible. If you don't have the facilities for the NICU, then you would like to go for in utero transfer wherever the facilities are available. If not, if you have the facilities, yes, you will go ahead with the management we discussed, and you will communicate with, once again, you will make a follow-up of this woman to have the, dynamic studies of the cervical length, whether it is really going down further. So transvaginal cervical length measurements, maybe you go for dynamic studies over a week, whether there are changes. Again, it is becoming shorter and shorter. If at all so, then you have to communicate with the multidisciplinary team, discuss the plan with the woman and the relatives, and of course, you have to do the clinical reassessment as well. So all these things have to be considered. You have very well discussed the role of tocolysis, yes. And how long? Not too long. We have said only till the corticosteroids work. So maybe 48 to 72 hours at the max. And the progesterone at this stage, definitely, I think we are not using the 17-hydroxycaproate nowadays because of reasons very well discussed. And yes, vaginal progesterone we have been using to prolong the pregnancy. Steroids and magnesium sulfate you have very well discussed. Now coming to the tocolysis, we have various agents. Can somebody talk about the various agents of tocolytics and the pros and cons of each? Do we have? Yeah, I think Dr. Sushma. Dr. Sushma we haven't heard you, I think, so you can take up this question. Hello, Dr. Sushma. Do we have the panelists? Hello. Dr. Sushma, I think we can, yes, Dr. Sonia?
Ma'am,
Sonia, Sri Lakshmi, all of you can discuss this. Yeah, yes. Dr. Sushma, I think is not responding. Yeah.
Ma'am, regarding magnesium sulfate, this is given for neuroprotection. But when we are giving magnesium sulfate, we have to be very sure about the deep tendon reflexes and the urine output, because it can cause respiratory depression. And so we have to take care of that. So, and when using caution with the calcium channel blockers, that now also we have to be very cautious while using magnesium sulfate. And regarding beta agonist, Ritotrine and isoxsupreme was the first line of management before. Now it has been replaced by the calcium channel blockers like nifedipine. Now the basic problem with isoxsupreme is that it causes tachycardia, and it cannot be used in, and it causes hyperglycemia as well. So it cannot be used in diabetic patients, and flushing, headache, these are the usual side effects with that. And even in hyperthyroidism also we cannot use beta agonists. Then we come to calcium channel blockers. Calcium channel blockers are the first line of choice at present. Now these are like nifedipine, which can be used 20 mg up till 60 mg we can use up to 20 minutes. And then by 10 mg TID we can use up till 48 hours. In calcium channel blockers, again, headache, flushing is one of the problems. Yes. And apart from that, we have got prostaglandin synthetase inhibitors, that is like indomethacin we can use, but that is to be used only in with polyhydramnios, because the side effect of indomethacin is it causes oligohydramnios. And ductus arteriosus, it decreases the blood supply to ductus arteriosus. So
yes, but our patient has got polyhydramnios.
Yes, ma'am. So that is why indomethacin can also be, but it has to be given with caution, with along with physicians' the advice, I feel.
Yeah.
And
Yeah. So what is, let us see what at Royal College of Obstetrician and Gynecologists talk about atosiban. It says that, atosiban should be the first line tocolytic for management of spontaneous preterm labor, and atosiban is recommended in the management of preterm labor. That is grade level 3-4 evidence that it has been stated in the RCOG, and I'm sure all of you know this. Just to read this dosage schedule or the regime for atosiban, that initially you give 0.9 ml intravenous injection as a bolus, and then the infusion rate of 6.75 milligram atosiban is given over, the bolus is given initially for 1 minute, and then the infusion is given as 300 microgram per minute, that is for 3 hours. Then we have to continue the infusion as 100 microgram per minute, and that is maybe up to 45 hours. That means as long as you want the tocolysis, that is how it is described. So what are the contraindications to tocolysis? So can we have Dr. Sri Lakshmi contributing to our discussion? Dr. Sri Lakshmi?
Yes, ma'am. Yes, ma'am.
Yeah, please go ahead. What are the contraindications? See, we have this patient who is in established preterm labor, almost we can say that she's heading towards preterm labor. So we are trying our best, and tocolysis is the mainstay because we want her to go ahead with the pregnancy. What are the contraindications for tocolysis?
Yes, ma'am. So first contraindication maybe is an infection, that we don't want to stop the preterm labor. We want the baby to deliver.
Yeah.
So if there is a definite definite evidence of infection like high grade fever, abdominal pain.
So chorioamnionitis.
Chorioamnionitis. Yes,
Okay.
we are not giving tocolytics. The second one is any cardiac conditions, especially stenotic lesions.
I think you divide the reasons or contraindication as maternal and fetal. Then you can get the better conditions where you can use and where you cannot use.
Yes.
So what are the contraindications for mother? Dr. Sheila Lohit, we were missing you, and we welcome you. If at all you can put in your inputs, that will be great. Dr. Sheila. Dr. Sheila has raised hands. Can we have Dr. Sheila? No? Okay, we can go ahead with the discussion. I can see here Dr. Sheila has raised hand. So do we have her in the panel, or she's wrongly joined in the delegates link? I can see Dr. Sheila.
Hello. Hello, ma'am.
Hello. Yes. I think I'm facing some network issues today. So I hope you can see the presentation. So do we have Dr. Sheila here? Sheila Lohit? Do we have? Or no? We can go ahead with Sri Lakshmi, what she was discussing. Yes.
Yes, ma'am. We were discussing the contraindications for
the maternal contraindications. Yes.
Yes, maternal indications.
Yeah.
Next, most important contraindication is cardiac conditions,
Mhm.
especially if there is a stenotic lesions like mitral stenosis and aortic stenosis. We should be very careful with the tocolysis. Even one single dose may cause a pulmonary edema and may put the patient into sudden breathlessness. Also, if we have to use a lower dose, and we should be vigilant for breathlessness and check for saturation if we are using for cardiac diseases.
Okay, so that is about maternal, that if she's got some cardiac lesion, you should not use. If she's got very severe tachycardia because of some other reason, if she's got chorioamnionitis, you should not use. Okay, and what about the fetal conditions where it is contraindication?
Fetal conditions, definitely. If there is a lethal anomaly, there is no point stopping a preterm labor.
Yes.
And especially anencephaly with the polyhydramnios, the most common cause. We have to enhance the labor rather than stopping the labor. The second one, again, chorioamnionitis, even the fetal infection, we should not stop it. And
if the fetus is dead, there's no point, there's no question of stopping the labor. There also you have to enhance the labor, right? And if you have a fetus which is compromised, a distressed fetus, there also you should not stop the labor. So all these are very practical points where you have to decide whether you should try and stop the preterm labor, or whether you can go ahead with the tocolysis. Now, how do you, I will ask now Dr. Sushma. Dr. Sushma, do we have Dr. Sushma here? I'm seeing one panelist here without a name. So can somebody identify herself? Dr. Sonia? I can see one panelist with SPECT, but then I'm not able to identify her. So Dr. Sonia, you can take up this question. How do you give magnesium sulfate? What is the regime for neuroprotection? And what is the evidence? Does it really work?
Yes, ma'am. The evidence says that magnesium sulfate works very nicely for neuroprotection, particularly in less than 32 weeks of fetuses. This magnesium sulfate can be given 4 grams IV loading dose, followed by 1 to 2 grams per hour in the infusion rate up till the time of whether delivery occurs first or up till 24 hours. It can be given.
Yeah. So it should be given for 24
acts as
hours.
a tocolysis as well.
It should be given for 24 hours. Yes. So for magnesium sulfate,
when we are
the monitoring is similar what you do for eclampsia management, right?
Yes. Yes.
So this is according to the NICE guidelines.
Have to be monitored.
Yes. Yes. So what is the mode of delivery for these patients, and what precautions you will take during delivery for this patient? Suppose she goes into labor. Dr. Sheila Loita, do we have her? No. So we can again go ahead. Dr. Pandurangaya, do we have Dr. Pandurangaya? No.
Sheila ma'am is joining now.
Okay, I could see her in the panel. I mean, the delegates, I could see her. So okay, so now Sonia, when you allow this patient for vaginal delivery, how do you monitor? What precautions do you take for her?
Ma'am, if I'm allowing her for vaginal delivery, I have to be very cautious about her antibiotics. I have to be cautious about the fetal heart rate. I have to be cautious about the monitoring of her sugars, because she's a diabetic mellitus case. And then with proper this thing, I have to conduct the delivery. And even I can have a physician opinion also, so that if required, we can call the physician.
Yeah, and as far as possible, we have to give a generous episiotomy and good, okay? Because we want to really avoid stress to or compression of the fetal head, right? Though in theoretical aspect, they have said that, fetus is a good, forceps are also good protector for these preterm babies, but practically we don't use forceps for the babies, okay?
Because this case is a polyhydramnios, I'm worried about the cord prolapse and other things also. So
Yeah.
I have to monitor very nicely
Yeah.
because
So that is
suddenly
what, that is where
if
the
the
question
lung
comes
structure-
only when it is by head and when you can do the control ARM and the head gets fixed, then only you should allow this patient to go into vaginal labor. Otherwise, when you find that it is a transverse lie or a breach, then you have to go for cesarean section, right?
Yes.
Okay.
Yes,
And of
ma'am.
course, your anesthetist has to be well informed. Your neonatologist has to be well informed that this baby will need neonatal hospitalization, and of course, the baby will need NICU care. Okay. So, what are the problems in preterm babies? What care we should what care should be offered, Dr. Sri Lakshmi?
Yes. Preterm baby, most important worry is the hypothermia. So always keep the baby warm, and the first one. Second one is the weight gain. So it is the exclusive breastfeeding. But these are the two most important thing that we should do for a preterm infant. First is keep the baby warm, and the second one is exclusive breastfeeding. So if it is extreme preterm baby, then we may have to teach the mother about kangaroo mother care. That is very helpful for the preterm infant.
Yes.
Then the third most common problem that we can anticipate is a hyperbilirubinemia. Especially this is within 24 hours, and this is very
What did
important.
you say? Just to repeat, what did you say as the first problem for this baby?
Is hypothermia.
This lady is a diabetic, so
Yes.
will it have also hypoglycemia? Yes.
Hypoglycemia and hypocalcemia and hypomagnesemia.
Yes.
So they are the metabolic problems.
Yes.
So first for the hypothermia, especially extreme preterm, if it is less than 1 kg, we have to teach kangaroo mother care for mother. Second one is second one is hypoglycemia, hypocalcemia, hypomagnesemia.
Yes.
This can be far and most prevented if it is possibly an exclusive breastfeeding.
Yes.
If there is a poor suckling, especially preterm infants, they have poor suckling as a practical problem, then it is a express breast milk is the other choice.
Yes.
But express breast milk to be as far as discouraged, because there is a more chance of infection, and we have to teach aseptic precautions for the mother and nursing mothers as well.
Correct. Correct.
Yes.
So exclusive breastfeeding preferably as far as possible. Yes.
Yes. And the last the problem that we should anticipate is hyperbilirubinemia.
Yes.
What we should know is the hyperbilirubinemia for a preterm infant, the values are much lesser when compared to a term infant. It is even at 12 and the 15 bilirubin may cause a very exaggerated hyperbilirubinemia.
Yes.
And that may have a long lasting effect. What is more worrying with all these complications is hyperbilirubemia and hypoglycemia, because they have long-term problems with the rather than hypocalcemia. Hypocalcemia is just a that time problem. If we can correct it, it will be fine. There won't be any long-term problem. But
So very well discussed, Dr. Sri Lakshmi, and yes. Dr. Sheila, we welcome you and will be including you in the discussion. And as you can see here, the immediate problems, as you have very well narrated, the immediate respiratory distress syndrome, and of course the hypoglycemia, hypothermia, hypocalcemia, and so many other problems of the baby, that is that they are immediate ones. The baby is more prone for infection and the prolonged exaggerated physiological jaundice, or maybe it may be so severe that it may even require the exchange transfusion and all these things. Of course, the long-term complications, and these babies, when they are put in NICU, they receive the hyperbaric oxygen, and because of this, even the the retrolental fibroplasia, the blindness, deafness, and
Retinopathy.
retinopathy. All these complications may also develop, and not to forget the cerebral palsy and the long-term, neurological complications, including the cognitive and behavioral problems. So all this why you have to know this? Because you have to explain it to the parents that yes, even if we can deliver the baby, successfully and uneventfully, these are the problems which are inherent to the preterm labor and delivery. So, Dr. Sheila Lohita, we welcome you, and now we go ahead with the third case from you. So, we have this 28-year-old primary gravida conceived with IVF, twin gestation, and now she's 29 weeks. She presented to you with labor pains, 29 weeks. When you examine her, vitals are good. Uterus is 34 weeks. The head is fixed. Okay. She's got
Yes,
three
ma'am.
contractions in 10 minutes and each one lasting for 25 seconds. When you do her internal examination, cervix is 3 centimeter dilated, 60% effaced, transition -2. How will you manage this case?
Ma'am, firstly, I would like to admit her.
Yeah, and what is your diagnosis for this patient?
It is a preterm, ma'am. Threatened preterm.
Is it threatened preterm or is it established preterm?
Ma'am, cervix is 4 if it is less than 4 centimeter, I think.
Yes, that is what I want you to discuss. If it is less than 4 centimeter,
I can wait up to like 4 centimeters. Like up to 3 centimeters, I would like to go for a expectant management itself. Give her time for like if I have NICU facilities with a good neonatologist, I would like to admit her in my hospital, or else with mother, I would like to shift her to a facility where there is good neonatologist and NICU facility. And then
whether you will allow her to go into hello, Dr. Sheila.
Hello.
My question
Yes,
is whether you want her to allow her to go into labor or you want to prevent the further progress of the labor, because she's not into
I want to yes, ma'am. I would like to prevent her into going into labor because she is still 29 weeks. At least up to 34 weeks or 32 weeks, I'd like to prolong by giving her steroids. And if investigation shows any like infections, I would like to treat her with antibiotics, give her good bed rest, then keep monitoring her with the fetuses with ultrasound and all.
Okay.
I would like to wait, ma'am. If she
any role for cervical cerclage?
Oh, madam.
I don't think so, ma'am.
You would like to go with the
Because
expectant.
she's already 3 centimeters.
Yes, that is what somebody is speaking. May I know your name? I have been
I'm Hema. I'm Hema. I'm Dr. Hema Mohan, madam.
Hema, yes, I was calling you since long. Yes, please say something. Yeah. Well, so
Madam,
because it is 3 centimeter and it is not even, I mean, it is 60% effaced. So it is only 29 weeks. So if at all you can achieve 34 weeks, do you really want to, the uterine size is 34 weeks because she's twins. Okay. But the the gestational age is 29 weeks. So do you really want to plan for cerclage? Because with cerclage, you may prolong the pregnancy maybe around 6 to 8 weeks sometimes. So do you want to go for cervical cerclage, which is called as rescue cerclage? Okay.
Yes.
Any opinion, Dr. Hema? Yes.
Yes, madam. I would like to go with the cervical cerclage with a modified iron Donald's technique or with the worms procedure, madam.
Okay, please let me know how do you do that.
Yes. Sorry, madam.
Yes, how do you go ahead with the procedure?
I would like to go with the modified Donald's procedure, madam.
Yeah, okay.
Yes. Like because the cervical length is like almost around 3 centimeters, I would like to go for the emergency cerclage.
Okay. So yes, definitely you can go ahead with the emergency cerclage. That is what the message is. So you try your best for everything. You try tocolysis, give her steroids, give magnesium sulfate, give her head low position to avoid the pressure on the cervix. You know what is Ferguson reflex? With further pressure on the cervix, it gets dilated and even the contractions are stimulated. Yes. So that we want to avoid that. So all this with definitely you can go ahead with the cervical cerclage, which is called as the rescue cerclage, because if that is supported, the membranes are also well supported and the os is closed, the further dilatation can be avoided and the tocolysis will take care of the contractions. So your hopes are, you are still hopeful to pull this pregnancy ahead. Okay. So now we have this one more patient, 30-year-old. Third gravida, I think we'll take this as the last case. Is it okay, the panelists?
Yes, ma'am.
Yeah. So,
Sure, ma'am.
yeah. So, do we have, whom do we have now as panelists who will be discussing? I can see 3 or 4 people only. Dr. Sonia and Dr. I think, yeah, the Lohit. Dr. Sheila.
Yes, ma'am.
Yeah, because you joined just now, so I will go ahead with you. So we have this 30-year-old lady, third gravida para 2. Both the babies died, and she comes to you with 14 weeks of gestation, previous 2 preterm deliveries. Okay. Now 27,
Yes,
27. I mean, previous 2 preterm deliveries at 27 and 25 weeks. Okay, and she's under your
Yes, ma'am.
antenatal care now. When you do her
Yes,
ultrasound, the cervix is 3 centimeter, os is closed. Whether
Yes,
you
ma'am.
like to, what is your diagnosis for this patient? What is your plan of management? Let me hear from you first.
Yes, ma'am. Ma'am, sorry for interrupting, but I have joined this session from beginning itself, not now.
Okay.
And I was there through all the session.
Yeah, but we
It's
were
only like
inviting
some
you.
network problem.
Okay,
Yeah.
we were
Ma'am,
inviting
firstly,
you. Yeah. Please go ahead.
yeah. Firstly, I would like to know what is the cost for her previous 2 pregnancy losses. I mean, preterm deliveries. And
Irrespective of the loss, we have discussed that if you have to previous preterm birth, she is again a very high risk for preterm labor.
Yes.
And irrespective of the reason, and she's got 2 preterm births. Okay.
Yes, ma'am. I would like to start her on progesterone. I would like to start her on a cervical insert clutch. With all the measures, I would like to prolong her pregnancy, ma'am.
Yeah. So, so with what kind of stitch you will give her?
Ma'am, vaginal McDonald stitch.
Okay. So, Dr. Sonia, any opinion, difference of opinion, or you want to go ahead?
According to the guidelines for the cervical clutch, if there is a history of preterm delivery, 2 or more preterm deliveries, we should put a cervical clutch.
Perfect. That is what the message we want to give. See, the evidence says that cervical length of less than 2.5 centimeter, then only we should label it as short cervix, and then only we should give cervical clutch or vaginal progesterone. That is what the FOXY, ICOG and FIGO recommendations. But when you have recurrent preterm labor, irrespective of the cervical length, we should be giving the prophylactic cervical circuit. Okay, so that is what the message, very clear cut, we have to give it to the so the risk reduction. How do you go ahead? You have to take a comprehensive history review. You have to come see the patient psychologically, as well as we have to try and tell her regarding the lifestyle modification, as if at all she has a history of smoking, or if she has the lifestyle is very heavy working or strenuous exercise also, that we need to modify. If at all she has bacterial vaginosis or maybe lower genital tract infection, then you have to offer the treatment for the same. And bacteriuria symptomatic, yes, we have to treat these women. We have to go for the cervical clutch irrespective of the length of the cervix. That is what the message here, though we have to go for the dynamic study of the cervix initially. If it is even though it is 3 centimeter, you find that over a period of a week and the next week it gradually decreases. The cervix becomes shorter very significantly. Now, what is this actin parter? It's a qualitative immunochromatographic test designed to detect the phosphorylated insulin-like growth factor BP1, that is binding protein 1, and in cervical secretions during pregnancy, actin parters. Okay. So if this is detected, then of course this is detected when the delivery is imminent. So if this is found positive, then of course you have to go for all the interventions possible to protect this pregnancy for preterm delivery. Any comment on the fetal fibronectin? Anybody has the experience of using this as a screening method? We can have Dr. Sonia's opinion now, and then we can again go to Sri Lakshmi.
Ma'am, fetal fibronectin test, I don't have my personal opinion, but then the guideline says that if the fetal fibronectin, because it is acts as the addition between the placenta and the chorion. So what happens is, it is a very good test to diagnose within 7 days, the expected delivery within 7 days, if its value is greater than 50 micrograms.
Yeah. If the test is positive or negative, that is.
So,
yeah.
Treated according to it.
Yes.
Very good up to 34 weeks, because after 34 weeks also it is said that it is secreted. And so it is a very good method nowadays to be done.
Okay. So what treatment options you have? Suppose you have this patient as, so for this patient, in addition to cervical stitch or cerclage, what are the other options? Dr. Sushma, Dr. Hema, can we have your opinion?
Then we can supplement with the progesterone, madam, to continue the pregnancy. Yeah. Then a cervical cerclage will help her up, madam.
Yes. So it can be, yes, somebody was talking about, I think Nagaraj sir was talking about some cervical caps. So you do have cervical pessaries, you know, the Arabian pessaries, that is what, if at all I have the picture, I can show you. But let us, before that, let us see what the choice of prophylactic vaginal progesterone and some progesterone and cervical cerclage. This was a, you know, the FIGO has tried to combine the study, and it has come to a complete it has come to the conclusion that whenever you have a short cervix, then the vaginal progesterone is equally effective as the cervical cerclage. So the results are comparable. That is what the evidence says. And of course, SCOG committee opinion is that a woman with singleton gestation and a prior spontaneous singleton preterm birth should be offered progesterone supplementation starting at 16. So if you have history of preterm birth, where you have recurrent preterm births, that is a patient who is very high risk, you don't just depend on the short cervix, but also try and supplementing vaginal progesterone right from the 16 to 24 weeks, regardless of the transvaginal cervical length, to reduce the risk of recurrent spontaneous preterm birth. Also, it is recommended that it is a recommended management option to reduce the risk of preterm birth in asymptomatic women with a singleton gestation without any history of preterm birth where the cervix is short. So where the cervix is short, definitely you go for vaginal progesterone. But where the cervix is not short, but you have a history of recurrent preterm birth, there also you have to go for vaginal progesterone, and then of course cervical cerclage. So this is what is the Arabian cervical pessary, and the many studies have been going on even in some centers in India as well. So it reduces the risk of preterm labor. That is what it has been, I mean, it has been stated, but we are still waiting for the evidence. Okay. So I think with this, we try to wind up our discussion. And I just gave you one algorithm here, that if you have a patient suspected preterm labor, depending upon the gestational age, you want to take this pregnancy to at least 34 weeks. But if the pregnancy is less than 30 weeks, then of course you have to treat the preterm labor by short-term tocolysis. You have to prepare the fetus by giving antenatal steroids and magnesium sulfate. And where the facilities are not available, you have to transfer, make the in utero transfer. If you have a pregnancy more than 30 weeks, then you have to go for transvaginal, the cervical length and fetal fibronectin. So if the facilities are not available, it's very simple, that management remains the same. But if you have the facilities and your patient is educated, asking you for all the evidence, then definitely go for the investigations. So cervical length, if it is less than 1.5 centimeter and the fetal fibronectin is less than 50, then you diagnose it as preterm labor. If it is cervical length of more than 1.5 and fetal fibronectin is more than 50 nanogram %, then she's not in preterm labor. Just think of some other reason and, you know, try and monitor her. And once you are sure that she's not going into preterm labor, then you can discharge the patient. But when you have the evidence of preterm labor, you have to give all the method or whatever modalities of tocolysis you have, and try and take this pregnancy to 34 weeks at least. So preterm labor is definitely a matter of concern, as it's a major cause of perinatal morbidity and mortality. As all of us have been discussing, prediction, prevention, and if no contraindication or no contraindication to tocolysis, of course, we have to detect at the earliest and manage it successfully. We have to optimize the treatment, which is evidence-based, and not to scare the patient and relatives, but simultaneously you have to see that we take the patient ahead, or take the pregnancy ahead and prevent the preventable preterm labor. Of course, we have to see that the quality of life and the intact survival of the baby as well. So with this, I thank the organizers, and I thank all the esteemed panelists who have contributed so very well in this discussion. And I take this opportunity to humbly seek your blessings and wholehearted support for my candidature as FOXI Vice President West Zone. The voting has already started, and I'm sure all of you have received the voting link on your personal mail or SMS text message. Please go ahead with the voting process, and please do vote positively for me. I am working hard for FOXI since last 20 years. And just for my introduction, I have been working as a very hardcore obstetrician since last 30 years. So thank you so much once again, and over to you, Dr. Raksha. Dr. Vidya, if you are there, please, we want to thank you again, and we want to have few comments from you.
Thank you, Dr. Sneha Buyar, for that excellently moderated panel discussion with lot of take-home messages on a very practical topic of preterm labor. Though it has clear-cut guidelines on in terms of tocolysis, antenatal steroids, max self neuroprotection, and all that, case-based individualization is the key to successfully managing any case. With this, I request our key coordinator, Dr. Sonia Batra, Secretary of Shimoga OBG Society, to propose the vote of thanks.
Thank you so much, Raksha ma'am. Ma'am, Dr. Rakshi Paradi madam had given one message, and Dr. Vidya Tobi madam is also there. If they are willing to give their expert comments,
yes,
they can
Dr. Vidya, we invite you for.
I am there, and I was listening to the excellent panel by Dr. Sneha. As usual, the panel was excellent, as well. Moderator and panelists did very well. So, and I think it is 10, but really, I was also glued to the whatever discussion went on. So, I think we can implement some of the things which were discussed. Everybody's experience is different. Everybody is tocolite takes the usage, and their experience is different. And I feel that this will be very useful. The only thing is, Sneha has joined, and I also have appealed to everyone that they must 1 to 10th is a voting date, and please see that in your respective societies, maximum people vote. So in the West Zone, there are 2 votes. So 1 vote should go for Dr. Sneha. That's what my appeal is. So thank you very much, and Shubharatri, good night.
Thank you so much.
Thank you so much.
Thank you much.
I really thank Dr. Vidya Tobi ma'am to grace the occasion, grace the session, and entirely from beginning till the end, ma'am was there with us. And thank you so much, ma'am, for making your precious time for this session and giving the opportunity to Dr. Shanta ma'am so that we all could arrange like that. And I would like to thank Dr. Sneha madam, and I would like to give her best wishes for Dr. Sneha ma'am for her upcoming elections. And most of us have already voted, madam, so don't worry about it. I still remember the last session. It was a breast committee this week only. Last year we had a session, and madam doesn't mind all going for panel discussions, elaborate discussions also, even if it continues up till 10:30. She's so much dedicated. I've seen her for a long time. And thank you, Shanta ma'am, for giving us the opportunity to actually have this topic of preterm labor in elaborate way, because many see such cases, but these stalwarts make it a way superior. I mean, so that is why thank you so much, ma'am. Thank you so much, Raksha ma'am, for mastering the ceremony, and we had a great time over here. Thank you so much, Vishalakshi ma'am, for chairing the session. Thanks all the panelists, Dr. Emma Mohan ma'am, and Dr. Sheila Lohit, Dr. Sri Lakshmi ma'am, and thank you so much, Shield Connect, from Sahiti from Shield Connect also, because it was all done in a very good way. We didn't have any problem. So thank you, Sahiti. Thank you, Shield Connect. Thanks a lot, everyone.
Thank you, everyone. Good night.
Thank you.
Please keep up the time.
Special thanks to Dr.
Please
Shanta
keep up the
Shekhar
time next time.
for taking all the
It was a
efforts,
pleasure.
coordinating with everybody. And thanks to Dr. Raksha for wonderfully moderating the session. Thank you, dear Dr. Sonia, and all my wonderful panelists. Thank you so much, all of you.
Thank you.
Good night.
And good night.